e kgolo-kgolo. Ya ke kopa re tseneng re ikatametseng re kgone ho simollang ka lenaneo la rona akere. Ko morao ko ntle ko ditafoleng ko re kopa re le gololle batho mo ba kgone ho tsena akere. Re le file monyetla ko ntle ko. Dumela. Ya ke a utlwala akere. Ra simolla banong gore a ile gore a wa dula mo fatshe bese ya tsamaya akere. Ya ke bese ya Elia ke bese ya Elia gore a ile gore sambano kata ra tsamaya rona akere. Ere ke le dumediseng kaofela ra le ratane, we love you. A rataneng fela man gore wa itse re no ratana ne. Re le rata kaofela. Ere ke ikitsising ko ntlheng nna ka lebitso ke nna Ezra Letsoalo. Ne ka lebitso ke nna Ezra Letsoalo. Ke nna modula stulo wa komite e shebaneng le mananeo a lefapha la tsa maphelo mo provinseng ya rona ya Gauteng akere le itse puo e or le batla ke bue ka dipuo tse ding. Alright, nna ke nna Ezra Letsoalo. I have the privilege because of you to be designated as the chairperson of the portfolio committee of health. We are from the legislature. The legislature is the provincial parliament. It's manzo amangana lo confuse. Gore bar legislature ke ngono fela ke parliament ya mo province. Eli bitsang parliament lona ke national legislature. Lona ke legislature. So rona re tswa from the provincial parliament. Ya lona ke re ke lona legislature. Asa rona re ba rumiwa fela rumile ke lona. So that is why ko ntleng re leboa lona for monyetla o. And that is why go le botlhokwa gore kgapetsa re ne ntse re boa mo lona. Re tlo fana ka tlhaloso. Akere ya gore mosebetsi o le rufileng lona ro tsamaisa yang. Ba le ba ile re mmaka mara mafapha rona ba tsamaisa yang manane wa bona akere. So ke ona ntse re tlise mo mosong wa gashego. Mare a ke tsamaye ke le one. Ke tsamaya le maloko a mang a komiti e shebane le mananeo a lefapha la tsa maphelo akere. Ke tlo ba kopa fela ba no re ba ikitsisi and then le no re shine wa itse gore le no ba acknowledge akere ikitsisi mme.
Good morning, everybody. Dumelang, Sanbonani. My name is Madeleine Hicklin, and I love being a member of this Health Portfolio Committee.
Sanbonani, good morning, Dumelang. Mina ngegama nguMalaza kaSkhosana. I also serve in the Provincial Committee of Health. Yala Gauteng. Thank you.
Dumelang? Le right? O ka ga le right. Le right? Ka nnete? Oh, I rathaba le right. Ka lebitso ke Matsiriso Mfikwe. Le nna ke leloko la Committee ya Health and Wellness ko Gauteng Provincial Legislature. Thank you very much.
Yeah, and then re tsamale ba dire mmogo ka rona akere. ba re thusang go tsweletsa mosebetsi wa komiti ko pele re na le mme mo le ba re ke mme Nondumiso e no re fela bonala mme emela o re tlhompe setšhaba ya ke mme Nondumiso akere August ke mme ba re ke mme August ba re kgwedi e le re fitile akere re tsamaya le mme ke doctor ba re ke Dr. Maggie Mokonoto ra ikitsisa re tsamaya le rre mo le kana rre ke mang o ikitsisa ba department a kere o na le farologano ke batlo le tlhalosetsa akere ra differa rona re tsoko lefapheng ke rona re shebileng gore lefapha le tsamaisa yang mananeo wa bona akere re tswa re le ko parlamenteng mare ka jeko re na le ba lefapha ba eteletse pele ke MEC wa rona ke re la mona Smiley that beautiful young lady at the far end akere ke tlo mo fa fela le ena itse gore o tlile le bo mamo akere yeah.
Sanibonani, dumelang, nikai. At least ningumuntu waseVaal sikhosana yawona. Angifani nawe. No, ndizama ukuzicela baba andihambi ndedwa. Ndihamba kunye no MMC we health walapha eSitibeng umama ulalo.
Ke nna mmelo la Mokwena dumelang Valley dumelang. Aye yesidibeng aye. Aye yesidibeng aye. Re na le MEC Vandaga hala thaba king. Ke so le bone. A ke bone joy ikae. Yes girl.
Thank you mama sizawuxoshwa mina nguchairperson nomamulana. Sizomosha meeting yase legislature namhlanje. Chair andihambi ndedwa ke ndihamba kunye ne group yami yase officeini ninzi kakhulu. Amantombazana aphi namhlanje angathi amantombazana nizanga nawo. Bazikhethile bodwa namhlanje. There are supposed to be about 5 girls that are sitting here. Nye nabo uyi-1 okhona namhlanje. Mncinci ungaka isana lam. So balidwa ngu-acting HOD. Our HOD is not around siyayaza ngithi. So kukhona ke ngoku-acting HOD kuthiwa nguDarion Buckley. But uDarion Buckley ungu-HOD we-department ye-COGTA. Namhlanje makufama kuzwe ngapha ngokuyo account ku-COGTA because all committees ziphumile ze-legislature. So saqonda uba kasusukwazi ukunidelela. Uye athi ke mayengekho uBuckley ku-actiswe u-DDG we-infrastructure ubaba uGalata. So nguye ke ngoku ongu-acting HOD for now ngoba ubaba engekho wethu. Ecani kwakhe phakama Galata bakubona abasebenzi nabantu abadala. Abazali bami bayakubona Galata. And then ecani kwakhe kunye no baba u-CEO. I know Hecklin, you always, this young man doesn't sleep. Hecklin, this is the culprit that you make him not to sleep. Stand up, CEO of Forensic Pathology Services. Yeah, he doesn't sleep. He knows he jumps. He says when he sees a call coming, he jumps. Then ekankwakhe kuno baba uDDG wethu kuma clinical services. Chief Operations Officer undate Dr. Slepe. Phakama Dr. Slepe akubone. Zonke izinto eziphayana zonke before ziyawufika pha kuGalata ziqala phaya then maziphuma pha kuGalata zizovela kumke ncwadi ntoni eyenzeka kwi-department sikhalazo everything ubaba uzithatha zonke ndimbiza unonto zonke because everything mangifuna ukuquestiona ngibuza yena akathi ngizawubuza next door. He must know each and everyone what is he doing. Ecani kwakhe kunalamfo ovimba gqithi imali. He holds our budget, is our chief director that is responsible for the whole budget of the province. Njengoba singabi na CEO, CFO nje, umane actor usebenza kunye nomnye acting chief director we supply chain esimthathileyo sam-actisa. So both of them, they are holding the monies at department. Phakamani Sambo and Mutweti nibonwe. Usambo no Mutweti. Makuthiwa kunakutya esibhedlele niyazi uba ndivinjwe ngala madoda imali yonithengela ukutya. Uba nifuna ukutya nithi nikutya ukutya okubi ngaba bakhuphe imali abo bantu babo ababenza bathenga ukutya okurayithi esibhedlele. So bona nje lowa ungasemva ke bekufanele uphakame kunye nabo phakama bhutwe payables. Lowa ungasemva ke yena ke ubhatala izinto abathe aba sizithengile esibhedlele. Yena is just responsible for payables. Any button ipresswa nguye. Ma epresse rongo sibopha yena. Ugama lakhe nguPhakamisa Jonas. Ekutanga Phakamisa Jonas is not Dr. Adele. Dr. Adele, he's an economist. Phakama bhuti. Hey, subaleka wena. You are too tall. He does everything in the department, Chair, including the assessments of us as a department. Are we doing things economically correct? Whether is it medical or what? Now there is a concept that we are doing called TTGs. It's called Treatment Time Guarantee. The problem that, Member Hicklin, you always ask us, you are having these patients in the cycle. When are you treating these patients? This patient went for an operation. When is this patient going to do this operation? If it's operation. If it's cancer, you took blood, and then when is this blood going to come back? So we've introduced that system now of treatment time guarantee. It's not there in South Africa. It's only abroad where we've learned it. So he's doing that, we're introducing it, but it tells us again, any operation now that is done in the hospital as we speak, Maslala on 12 midnight, we are going to know that Honorable Advocate was there, and this is the treatment that is taking. Doctor tells our men for 6 months class cycle, then you will go on under the knife on this date. So now we have that. We've employed interns, Madam Ukona, I'm happy. We've employed interns now that must work directly with the doctors, because sometimes we don't even see the files, what is written there. But those interns are closely monitoring those treatment time guarantee of our patients to avoid the backlog that we are having. So that's a new system that will come and present yourselves. So we have an app that we've developed. We launched it on the 18th of July, Mandela Day, because we want to link it on this surgical backlog chair that we are dealing with. So Adele is responsible for that. Because when I have a problem of accruals, he was working with the 3 boys in terms of dealing with our accrual strategy. Because always, whatever you do, you must start having an assessment. Let's check where we've made it wrong. So he does that work for us, Adele, in the office. Then next to him, we have CIO where Chief Information Officer. U-apply igama lakhe u-Anele simbiza AA, and then I'm proud of her. She's one of the youngest. She's a director on infrastructure, on ICT, something that we always think that it's for the boys. She's the one that is training now doctors on the clinical module that we must use. What you went to see there, Qatar, I was so excited. That's the best there. What you have seen, I'm sure Dubai General Hospital, they are doing exactly what Qatar is doing, because I was there. So we're trying to introduce that system in the department, and we've started already. We're at an advanced stage of starting that, but she's the lead in that project. And because it's a girl, it's going to run very fast. Trust me. So, Naboke, Pagama Puti, Dr. Matabata is the doctor who is responsible for clinical services as a DDG, now acting in the department. After sine problem yase Tembisa, we took him kulanda wechisayo. He was there holding the fire in Tembisa. Then we realized that asina TTG, Dr. Mankopane resigned, and then we had to rope him in. Sizombeka abe director wetu clinical service. A very humble man, but he can do his work that is given. Working very closely with Dr. Slepe. I have those two doctors that are so humble, that are able to treat even us in that department. Inabantu abahlanyayo, mawuthatha nabo ukale wehle ngoba because ufika upha and then akuthatha kubeke ezantsi. So Dr. Matabata, can you greet abantu bakubonile? Unamahloni ke. He's a very shy man. I've never seen such a shy man. And that is Slepe ufunga phakama. Pizzi, Ndate Pizzi. Niyamazi mos Ndate Pizzi. Women here and men, but mostly are women. He's a nurse by profession. Ndate Pizzi is responsible. He's the chief director for this thing here in different local. Yeah, and he works with all these regions. He's holding all the regions, and he is he was in Tshwane, Simkashele Tshwane, but because where I have a problem. But he's the overall chief director of all the chief directors in the regions. So Ndate Pizzi, utata wetu sonke pa, he ever smiling, humble again, but doing the work. Nizawubona performance here to now, even on the districts. It's because of Ndate Pizzi. It's not by default. It's the character that we have. No other regions want Ndate Pizzi. Because Nati Siamanyelwa ngui, Loani Yamazi, PLO Yami is always there. And then Abutiki director wa Mwepe is the strategist. I love his strategy, so because I'm a strategist too. He's the one that analyzes everything. Baba Lantubucho Sebenza, chief director, Adele, then he's a director. But Adelegan is on leave, he's studying, he's writing exams. Tizela Eval, these are my two directors from the district in the Val. Both of you ladies, Niazwagang Aban Balapa, were always together in the trenches. Can you stand and greet them? Yenusisu se mid-Val, but Yenusisu, she's the overall, now working with Ndate Pizzi. More of our acting chief director here working with Ndate Pizzi. Because Ndate Pizzi, if he's not here, she delegates them all the responsibilities. Hence, Dominique has so many responsibilities. Refile Pagama ngobufike late nana, and awufiki latest meeting in. And goes by Ndona namhlanje. That's our chief director for local health promotion programs. I'm sure before you go to bed at 12 midnight, you see all the regions doing activities everywhere. That's the girl that is responsible for that. All the local health promotion programs, working very closely with Ndate Pizzi at the provincial level. These are my two TTGs, Pagama TTG bakubone. UTTG wetu Pasani Baloyi. We cooperate. Kasha yenapa. All these things ezenzekayo. She's a hard nut to crack. She is here. Nangokune court case yabantenza kuxolela ngayo Masipumala. So she's there. Others are not here. Legal services is in court. There are some cases that they are dealing with in court. I want to apologize on their behalf, say up front. So this is the team that I have. If there is anyone that will come, we will introduce as they come. But they are ready. It's a capable team, Chair, that I think it's ready to handle anything that you want us to do. But I want to thank you, Chair Futhi, because you're going to see a different report from the last quarter. It didn't happen because of us. It happens because of the interrogations, the visits that you have done to the hospitals. And I'm proud standing here now that my quarterly report is better than the first quarter. And I want to move, and even the third quarter must be better because of your help. Should we have not done what you did, we wouldn't be where we are as a Department of Health. So please don't shift pedal, because it helps me too. Press that pedal so that we can move as a department. Ngiyabonga kakhulu.
No, thank you very much, MEC. Really, we are MMC, Mema Ngubi. Ke bona o batlo ntsela ntshwaka ma. A ke re mo ke nna ka shego. A no ke bone batho ba ba le teng ke re MMC o batlo ntsela motšhini bano. I quickly want to check whether we've got our councillors here. Do we have any of our councillors? I know what we ke a manye kana e ka ntate Hlanyane ke a manye ke a Hlanyane o kae mo councillor a gono fitlo na le ma councillor a mang hona le ba bogoshi a ke re nako nngwe o na le bogoshi o kry bo le teng re acknowledge a ba teng o na le baruti a ona baruti okay yeah so re tlo starta formally ne mare ke batla gore before re starta ko re no bulang fela ka thapelo man a ke re rona re batho ba rantsho manane wa rona ra simolla ka thapelo ke mang fela a ka re rapellang ka jeko ko re a ka ithaopang fela gore a ke a etse ya ntshwe tshwara ntate tshwara o e otle mo thapelo nyane khutshwane ko re se kwa kopa dilo tse ngata fela poloko fela
Dumelang baahi. Ke a qala ke rapela he. Modimo mosakonyana o loka lesika la bophelo ntate a matla hohle. Ke a tumetsa didimo tsohle ka re tuele sebaka sena konyana o loka lesika la bophelo. Ke ba kopela matla ntate a matla hohle le hore ba kgone ho beha ditaba tsa bona re kgone ho utlwisisa. Ka re tuele sebaka sena re a leboha ka mabitso a mararo amen.
ya moruto nka tsena kereke ayo o re nka no ya fela every Sunday oye ntate ke kana ke yo ntate ke kana tla o dumedise setšhaba fela o fane ka tlhompho mo setšhabeng o ba dumedise ke morafe wa ona a re fe ntate ke kana sebaka fela le dumediseng ka bokhutswanyana ke
Moshate le kae kaofela? Dankie.
no ra leboa ke so e re ke le feng tsamaiso ya rona ya lenaneo la rona ke re o robere ka bjang a re kopane so the way re kopaneng bofelo bo according to melao ya legislature or ya provincial parliament ra declare ka more bofelo bo will be deemed as if the precinct of the legislature ona le molaotheo mo le ba re ke rule 56 a ke re it means maitshwaro a rona mo tsamaisong ya meeting wa rona a tshwantse a tshwanakane le maitshwaro ya maloko a legislature a ba na le dikopano tsa bona a ke re so re tlo ikeletsa boikopelo bo tswetswe gore a e le gore motlhomo o na le tšhisego ya gore o ka ntsha ntlha e rileng gore e rileng o tshwantse o emele karolo eo ya lenaneo le a ke re so a re bui fela and meeting wa rona tshwantse o nne le direction a ke re meaning that a re nne ntse re emelela re tswa fela randomly difounu tsa rona di renya because otherwise it undermines the spirit ya kopano ya rona a ke re so re tshwantse re tlhompane gore re kgone o le utlwa le ba e le gore ba tlile fo lona le bona ba kgone o le utlwelela a ke re la bona gore re kopantshe bomme le bontate ba lefapha so the whole of the department is here for you gore ba kgone o fana ka dikarabo ba kgone o fana ka tlhaloso mo tse e le gore le itemoela tsona a ke re mo e le gore motlhomo no ba tlo bontsha gore no mara rona re thabisitse ke selese le yona wa e bua a se session a dingongore go fela a ke re so ke feditse ka ntlha eo ya bobedi ntho e re ditseng gore re lebitse the way re lebiditse mo mosong wa kajeko kore kgapetsa re na le rona re le maloko a komiti re kopane le lefapha le fane ka diripoto tsa bona gore ba ntse ba tsamaisa ya mananeo a rileng a ke re whether ke lenaneo la gore bona ka bo bona ba ithulagantse yang as administration ra tlhatlhoba whether ke lenaneo le le gore le shebane le dipetlele tsa rona ko provinceng dipetlele tsa rona motlhomong tse e le goreng ke di-district regional tertiary le tse ding tsa ditleliniki tsa rona ra tlhatlhoba a ke re go na le mananeo a mangwe a shebane le di-ambulance le ona ba na le gore fa di-reporto gore lenaneo le tsamayana go na le bofokodi mo go na le bokgoni mo so re phela ntse re ba tlhatlhoba a ke re go na le tse ding tse e le gore di relate to di-health training le tsona ra di sekaseka gore ba tsamaisa yang mananeo a so go na le mananeo a farologaneng a e le goreng overall makes up the deliverology ya ditshebeletso tsa lefapha la tsa maphelo a kere gore ditleliniki tsa lona di tolame di kgone go tsamaisiwa ka mokgwa o tshwanetsweng gore tleliniki nne le ditlhare nne le bomme ba ile gore ma kgone go thusana le lona ba ile gore ke di-nurse go nne le di-doctor go nne le dilo tse tsotlhe the same thing le ko dipetleleng tsa rona kere o ra o ile ko sepetleleng ha o tsena ko sepetleleng e be le gore le wena pelo ya ya nolofala gore ke tlile mo sepetleleng ke kry-ile thuso or motlhomola e le gore ba kry-a thuso go nne le section e le gore o kgone go tsenya ditletlebo tsa gago gore ke lela ka selese a kere and then ditletlebo tseo di kgone go saliwa ko morago so all of those things they form part of the programs tsa lefapha la tsa maphelo and that is why le bona bo mme le bontate mo ba le teng gore ha e le gore motlhomong le ka nna le dipotso tseo le tle le lona le kgone go nna le monyetla wa kgone go di botsisa kere and then dikarabo tsa teng le kgone go fiwa tsona so what you are going to see go tlo present a report ordinarily in the legislature every 3 months ntho e re bitsang re ke quarter re bitsa lefapha gore fanang ka tlhaloso gore le tsamayang every quarter so every 3 months without fail akere but in between those 3 months re kgone ba bitsa anytime gore MEC re bone se le se mo dikuranteng or re utlwile se bua ke setšhaba sa ko Sebokeng akere setšhaba sa ko kana ba re ke eng otwane kwa ko karo yang ko dipaleseng ke ko kae kwa ke ko Lesedi ko Lesedi kwa kere setšhaba sa ko Lesedi se lilo re a ra kgotsofalla sepetlele se go na le makoa mo le mo and so on akere so the length and breadth of our province so department e re service kaofela in the province but here's the unique thing ama service fela rona batho ba mo Gauteng so ke batlo le tlhaba botlhale because nako ngwe re na lona no re no lefapha le le shebile fela batho ba mo Gauteng Gauteng health system e representa ntho e re bitsang re ke national health system because le batho ba tswang ko bo Mafikeng ba tswa ko bo Taung Northwest as a whole ba na lo ikry-a le gore ba referetswe kamo because ke rona ba ile gore re na le dipetlele tse dingata akere Gauteng e na le 37 hospitals 37 and then I know o na le se se mo ke Johan Mays akere se le gore sa lokisiwa so buliwa it will be a district hospital and then there will be 4 more hospitals that will come. One will be in Davidton, another one in Olivenhout Bosch, another one in Shoshanguve. Where am I forgetting? I'm forgetting the 4th one. Orange Farm. Another one will be in Orange Farm. I get it. But in between, there may be other decisions that are made to build the other health facilities. It could be clinics. I get it. Thuso a kry-e o ifela ko dipetleleng rona batho ba bo rona re na lona no ra o lwala o pale ke tlhogo o tshwanetse o mathele ko sepetleleng kgante nako nngwe o tshwanetse fela o ye ko tleliniking o thusiwe koo a kere ke yona ntho e re bitsang re ke primary health care so ka bokhutshwanenyana re tlo kry-a reporto e recordang performance ya department for the whole 12 months a cycle a kere for the whole 12 months a cycle gore since re fetsa mo ngwagong o fetileng le ntse le ipereka yang a kere ke mo kae mo le gore le bone fenyello kgotsa ke mo kae mo le gore le nnile le matsapa and a ile gore o nnile le matsapa le lokisa yang a kere and then what are some of the newer innovations that you are coming up with in between a kere so ke yona puo e le gore re tlo e utlwa mo mosong wa kajeko so, rata uitaro you must enrich the discussions. Government ke government ka batho. A ke re la utsi molaotheo wa rona wa naga, constitution. Or golomente ya rona is structured in a two-folded fashion. It is both a representative and participatory. So, lona le setšhaba when there are decisions, such as in these meetings, you must participate. Otherwise, batho ba feleletsa ba ikeleditse dilo fela. Akere, e le hore ba tlhabiwa botlhale ke setšhaba. So that is why re tlile mo setšhabeng gore e re tle re tlo utlwa setšhaba. Bomme le bontate ba ba leng teng ba maloko a komiti setse ba sekasekile report e. Akere, ba setse ba buisitse ba engage the department on your behalf. But it's not enough. Re ba tlo utlwa le lona. Gore le rona re kgone ho tia ka di input tsa lona. Akere. So ntumelle mo sebakeng sa ona no re tlo hand over. But before we do that, two critical things. Hona le motho o mong ba ile hore nga ba kgone ho utlwa dipuo tse di rileng. Akere motho o mong report o ile presentiwa ka Sekgowa wa kra ile hore Sekgowa kra se bua rona. And ntho ya Sekgowa se it's not a measure of intelligence. Akere a be re na lo swangelana ka Sekgowa. O kre motho a bua Sekgowa mara a chaile. Wa se nang tšhelete gore Sekgowa se pala. So it's not a measure of any intelligence. Wa itse o ka ya go mafatsheng a mang gore o tla bona magwa ba sa itse le Sekgowa. Gore se pala ona mo Europe e seng go kae. Ke rona fela mo ba Africa mo re swangelana ka bo Sekgowa. O nyako bua mantswe a makimaki. A ke itse why batho ba rata mantswe a makimaki. Kare batho kore ba sa utlwe o reng lo reng, you know. So ntse tshwantse re sekaseka. So hona le la bona di ntlwana yana tse le go morao tsena. Ba re ke di translation booth. So ba ile hore motlhomong ka report o e tlo presentiwa ka Sekgowa. Ba feel hore ke batlo e utlwa ka puo e le hore e different. Ke emo e na le di channel ntshwele. Ha o batlo e utlwa ka Sekgowa channel 1. Channel 2 Setswana kapa Sesotho, channel 2. Africans, channel 3. Svenda, Tsonga, channel 4. And then, ba ile hore ba tlhoka hona le motho a sign language. O go ke? E la mona mme o mole. Mme ke mme wa tlo thusana le ba ile hore ba na le tlhoko ya sign language. O te motho a nang le tlhoko ya sign language, o sa kra re mo rile mme o le. Abe matso ana lo ala bisa ntso etsa fela o sna motho lo o tlhoka tshebeletso. O te motho le mitsi mo lona mo a tlhoka tshebeletso ele. Imagine a 3 hours ntso move matso. Go sna tlhoko eo. O te motho mar ha fitla a ke le tla re supetsa akere. Ko ra ile rona le motho mo o lo re la mitsi le mona tsena reactivator meola akere. Re ska mo mora thata. So ba ile hore mana le tlhoko ya tshebeletso ele le emisa fela matseo akere le emisa fela matseo le sa rase and then ba tlo le tlisetsa di ntho tse tsa o translate akere. Okay, no ntla e botlhokwa ba re sign language because re mo di social media motlhomo ona le ba ile hore ba go gaya akere. So o mo a ga e tlhoka ko so mme o tlo tswella. A ke re nkile ra bona ntato mong ka funeral ya ntate Mandela a rwa ka setšhaba nna re rwa translate na gante a rwa ka setšhaba so setse re tshaba a o lapile mme o na le wa o change-ang a kere o change o se kwa kry-a ano matsogo so tswa etsa fela kere ra gore fela so ba ile gore ba na le tlhoko ya tshebeletso ele emisang matsogo ba tlo le tlisetsa dilo tsene. And dilo tsela e re ke le botseng di na le tracker ka moara tsona. So re kopa ra o ya toilet or o tswa re kopana re nna e fedile o di tloela fela mo fatshe. Ka ra o tsamaya ka yona o lo tshwana le bo brown mogotsi o ikra o le mo mathateng akere o tshwana le brown mogotsi gore batle o bitswa go commissioning. So o itloela fela mo fatshe o tla boa o e kry-a o bo akere. That's the first thing. Second thing, ko ntle kwa msho le bone ntse le tsena kere go na le ditente mo le le utlwile ba re mme o teng mo o etsa health promotion. Re batla gore mo dikopanong tsa rona le tseng sebaka gore le itshekatshekeng akere ke ona monyetla o leng teng le check-e malwetse a o tshwanagana le bo ditsukiri high blood motlhomong HIV la check-a dilo tsa di sa tshosa ha ba di detectile early o kgona go kry-a thuso akere se ka kry-a o tshabile mole a re sa dilo tseo di tswile fashioneng tsa gore ke tshaba go testa gore ba tla reng ra testa akere ba bangwe ba rona re na le ona malwetse a already bo di-high blood re tsa dipilisi and re kgone go phela akere so re ra gore a re rotloetsaneng gore ha ntse re kry-ile monyetla fela quiet re eng fela re presente mole bomme le bontate ba ba leng teng ko ntle mole ba thusaneng le rona akere gore motlho o mongwe a e le rona le something else ba kgone go se detecta o kgone go kry-a thuso ka pelenyana akere so e re ke le leboeng re tlo tsena mo programmeng ya rona and re tlo movanyana ka speed akere because re senyegetswe ke nako so ke tlo fana ka monyetla ko MEC wa rona to present those that are going to take us through the annual report. Again, the annual report of the Department of Health. Kora re lona le privileged. Le privileged ka jeko because re mo tikologong ya lona. So ke lona ba lo reng le tlo representa setšhaba pharaphare sa Gauteng. So ba shebile lona mo di social media. Ore batho ba go valley in the main. Although una le ba bang ba ba tswang ko mafelong a rileng akere mara re kopane mo valley. Meeting wa swa batho ba valley fela. Kwa batho ba Gauteng pharaphare akere lo a leng ko the furthest point ya Gauteng la itse re ke eng? Ke Hammanskraal kwa akere furthest point or ba ile re mma ko Westland ba re ke go bo mogale kwa o phunyella ko le bona ba tle ba re shebile akere so you are going to represent them re kopa tswetswe kopano ya rona se ya municipality akere a se ya ditshebeletso tsa municipality nna re tletse fela tsa maphelo akere a ra tlela ore go na le di-storage mo ore ntate o nkubile ko ntlong ke tlile late ore mme wa nkgana re tletse fela tsa maphelo akere yeah so e re ke feng MEC and then MEC o tlo re thusa gore re itse gore ke ma presentang ntate Xolisane ke ena a tlo re tsamaisetsang report yo akere la mmona ke ntate fela lekau a gentleman le sa mo tshwenyang bo mme a tswa mo akere le tla mo dumedisa fela ma le se ka mo tshwenyang thata ntate Xolisane.
Thank you very much, Chairperson, MEC, honorable members, Dumelang Bagaetsho. As the chair has indicated, my name is Xolisane, my surname is Galada. Ntate Phuthi there today, Chair will be taking us through the presentation. The gentleman sitting on the far left. Ntate Phuthi, over to you.
Honorable Chair, honorable committee members, the MEC for Health in Gauteng, the MMC for Health in Citibank, good morning. Good morning to the managers from the Department of Health, as well as good morning to you. Setšhaba sa Citibank, good morning. Letsogile gantle. I'm not sure if you can see something on your screens. Maybe I think that's a try we fix them. No, I didn't. Yeah, just disappeared. Okay, let me do this. Yeah, there's still a problem. Actually, I'm not sure what's happening. Duplicated. Oh.
But they can see clearly.
Okay.
Yeah, because if you want to run it to the full mode, I think you have to put it at that side so it shall.
All right. Okay. Once more, Chavasareshu. Good morning. Why are you going to energy today? All right. So, Kitlo present. I'm going to give a presentation on the performance here department for the past 12 months. As you can see, the dates are there from the 1st of April 2024 up until the 31st of March, right? One of the good things about coming to a community is, and presenting this thing is for you to hold us accountable of what we have promised in the beginning of the financial year. And also for us to request your support on some of the areas that we are struggling with. Because some of these particular processes, they are dependent on you to come to our facilities. They are dependent on you to assist us with our ambulances as they come to your facilities. They are dependent on you to go and get screened. So that's one of the accountability frameworks that we follow in order to ensure that you guys hold us accountable. Let me go to the next slide. I hope the slides are visible on all ends. So the next slide, it just speaks about what are we going to be talking about today. And as I've specified that we'll be talking about the performance of the department, I will skip this abbreviations and speak about this for a little bit. So we are not just presenting these numbers. These numbers are audited by the approved auditing body. It's called Auditor General South Africa. So after we finish and we say, this is our performance department, they come and verify the performance that we are going to be reporting. And they have verified the performance, and they are saying we are remaining unqualified with findings. Meaning that the different areas that they have audited, they do not have material. The findings are are significant enough to affect the reliability of the information that we are going to be reporting on. So I will move on to the next one. So if you remember quite well, the last financial year was just a year before the elections. Remember we had the elections when? In May, right? That's where the 7th administration began, which is now the GPU, Government of Provincial Unity, right? So we had finished what we call the MTDP. These are just the plans of the government for this particular administration. And these have laid out very clearly, right? And if you look at this, here, we are trying to show the trends or na department ne performa jwang mengwaga e o ifitileo, right? And if you can look at it, you will see from your 2021, 2022, there is what we call targets, right? So targets are deliverables that are set by either international standards, like your 95, 95, 95, that says 95 people must be knowing their status. Of those that knows the status, 95 of them must be linked to care, and those that are linked to care, 95 of them, of course, must be virally suppressed. So those are international, and some of those are national. That I say, as South Africa, these are our priorities. And then Gauteng, this is your part that you're going to be working on. And as you can see, on here, we have been trying to show the trend over the years to say, in 2021, 2022, out of all the targets that we were given, we were only able to achieve 51% of the targets. But if you can look at all the different financial years, you will see in 2022, 2023, we improved a bit, and then we improved a bit in 2023, 2024, and now we have improved, we're on 60% in 2024, 2025. Please let's give that a hand of applause. Oh, we are not where we want to be yet. Although where we want to be, we want to see ourselves achieving 100% of our target. But this is showing that you don't eat an elephant in one day, right? It's a stepwise process where we see some areas of improvement, we improve on those, we perform better in the next financial year. We see some areas of improvement, and we do better as well. So here we looked at the different quarters, and I think this is just very clear to state that there is an improvement from the first quarter up until the last quarter. I think Chair has spoken about this. So every single quarter of this financial year, we are requested to go to the same legislature and provide this particular report to say, in this quarter, this is what we've managed to achieve, this is what we've managed to achieve. So that's how the legislature aims to also hold us accountable as well. I'm going to talk about this. So we spoke briefly about the various programs. I think the Chair has highlighted these programs. And these programs work together to ensure that we manage to deliver this kind of services that you all experience. I'll go into detail a little bit. The first program that you see is what we call administration. This is the program that is responsible for HR, your recruitment, is responsible for finance, is responsible for ensuring that our medical legal, when we get sued by the department, we're able to attend to that. It is also responsible for ensuring that our ICT infrastructure is also, in place and is of good quality. So this is an overall administration, governance, and accountability program. So all targets that we are speaking about, they are under the first program. The second program is about the district health services and inclusive of the health programs. So it's looking at all the different performance of all the 5 districts, your 3 metros and then your 2 districts, including the one that we are in at the moment. It is divided into sub-programs, and I will touch on those. You've got those that are focusing on our district hospitals. You've got those that are focusing on our mother, our child, our nutrition health. We've got those that are focusing on public health initiatives that we are doing, like screening that we're doing outside. Then our third program. Our third program is focusing on ambulances. You can see our ambulance personnel that are sitting here in front. So these are responsible for making sure when you call, they attend to your call and make sure that they deliver you to your nearest facility to receive care. The fourth program is the one that is responsible for a provincial hospital. So these are your specialized hospitals and also what we call your regional hospitals. These are just higher level hospitals that we have that are taking care, that are next referral levels from your district hospitals. Then program 5 is mostly for central hospitals, those Chris Hani Bara Hospital, Steve Biko Hospital, we call them the Big 7. We also have Tembisa in there, we have got Helen Joseph, we've got George Mukari. So those are our special, very high technical hospitals that are responsible for doing all these highly specialized surgeries, and they can offer all these services. And then program 6 is mostly for training. Of course, for us to have nurses, we need to train these nurses so that they can be absorbed into the system as time goes by. This is what program 6 is all about. As well as our emergency medical services students, that is what the program is responsible for. And then program 7 is mostly for medication. This program is the one that ensures that all your clinics, all your hospitals have got enough medication. So when you go there, you can be able to access the medication and be able to get care. It's also responsible for what we call CCMDD, that Central Chronic Medication Program, whereby when you are a chronic patient and you are stable, we refer you for care. and then you can collect your medication within a designated healthcare facility. And then the last program, program number 8, is about infrastructure. This is where all the renovations that are happening, they fall under that program. They spoke about Johann Haynes being converted to a district hospital. That is exactly where we track that progress. This is where we get our new primary health care facilities, all maintenance-related infrastructure, they fall within that particular program. I've spoken about the 8 programs, right? So now I will go into the different areas and how we have performed in as much as these 8 programs are concerned. I hope I was clear. Was I clear? Understandable? Okay, you'll get it when I go into the next couple of slides. Let me proceed. All right. Okay, no problem. I will do that. Thank you so much. Let me continue. So, the first program that I want to talk about, where you see a thumb that is saying this, it means this is an area where we have actually performed. More kgoneng go achieve the targets tsa rena. Ke kgone explain the targets. When the targets again. So the first one is called a couple-year protection. One of the things that we are trying to do, a couple-year protection, ke contraceptives that we give to women of reproductive age. Or ba kgone access the condom, ba kgone access the loop in our facilities. So we have really managed to ensure that all the people that need these services, those kind of services, right? The second achievement within this program was with regards to the deliveries. So what happens, you know we have got a teenage pregnancy, we've been having a teenage pregnancy problem, right? But what we have managed to now implement is really what we call a teenage pregnancy prevention strategy. And a strategy se ke sa o dira gore bana ba rena ba banyane ba ska ba ima because mebele ya bona a se e be developed gore ka kgona ho handle a pregnancy. So what we have managed to do is we have managed to reduce the number of deliveries tja bana 10 to 14 years. You can only imagine the pregnancies in that particular. These are kids already. So for them to be mothers is really something that we are trying to prevent as much as we can. So what we did, we went out to say teenage pregnancy strategy, and then we wanted the number, they are reducing, right? The other one that we have managed to actually improve on is the mother postnatal visits. I think adding a little bit on that. Within 6 days, in the facility after us no give a birth. So read the assessment. More both ngwana le mma go checka gore di sa sepela ka mogwa wa tshwanelo na. Akere? So re kgona go bona gore actually now the females that are presenting in our facilities through our initiatives ba kgona go tla ka kua re kgona ba testa and re kgona make sure gore going forward health ya ngwana o monyane le health ya motswadi is up to standard. Again, the one thing here is drilling as well through our outreach activities in terms of nutrition ke go make sure gore the vitamin A ke di dropo tsela re di dropang ge ngwana sa le o monyane di important because di thusha gore ngwana a be le masole a mmele a strong. Akere? So ngwana ile o monyane sanetse gore mo fe di vitamin A gore gone go booster immune system ya gaga gore a gone go lwantsha le di infection. So through our outreach activities and processes re bone progress and we are able to give this to our young ones and re bona improvement year on year. The last one under mother and child health ke gore re bona improvement ga re sana bana ba bantši ba ile goreng ba tlhokofala ba under 5 years ba ile goreng ba tlhokofala in our facilities as a result of pneumonia as well as le diarrhea. So this is because we have implemented the training ko di clinicing tsa rena gore di clinicians tsa rena ko di clinicing di kgona go ba manager bana ba ge ba fitla kwa ka di complications. So when they are referred up to the higher levels of care, they are adequately managed and re kgona go prevent those deaths in those facilities. That is the first achievement, dear mother and child. Ke kwa ge tša kere le nkwešišitšane jwale. Aha. All right, a re tšweleng pele. Jwale, ka prevention ya mother to child, akere, I think in terms of achievements we are done. Ha re yeng jwale ka disease prevention. Le a re bona gore usually we are outside here. Re pitcha di tente, and then mo re pitchang di tente, re re itlang le tlo testa. Akere? Le ka mo ntle ka mo, chairperson o boletse gore o na le tente, le yeng kwa lo testa. Re screena diabetes, re screena di hypertension. So the ultimate aim ya re nyaka go achieve ke gore re kgone go tseba gore re kgone go identify earlier he le gore batho ba rena ba na le diabetes gore re kgone go manage e sa le ka pela, right? You know that hypertension is a silent killer. So ga se antse o ka e feela gore o na le problemo up until e ba worse jwale e ba stroke. Jwale the good thing ke gore we have managed to reach more people ka di program tsa rena le program called Corner to Corner. I run a program called Our Teach, which aims to go to township informal settlement areas. And these are the little hostels. These are the programs where we go. And then we call it generally as if a healthy GP. Having healthy Gauteng. So these are initiatives that did around risk and hey, Lorna Matata. Rehono pick up as a lega again. Moving on to the next one. Yekabolanka yona is what we call a HAST. So HASTIC program may aimang go manage HIV and AIDS, HA, STI, sexually transmitted infections, as well as TB. Like so HAST kiona program ye le horing e emo dira ka mgo. So the first thing ye re dire gore re tsebe gore ona le HIV, ona le TB, ona le STI, ke gore re screen. Hager? So ere ka khona ho screena. Re bona improvement, of course, because of our facility-based HIV screening processes. Batho ba bantši ba tla ra ba screena for HIV, hape HIV ha e sa bolaya matšatši. Hager? So re a bona le confidence ya community e kgona go tla e kgona gore ba kgone go screeniwa for HIV. So we want to increase in terms of those. As well as the NPOs. There were NPOs that were previously contracted during this financial year. Wherever it to ka reach batho. Be re ka khona ba screener, re khona o pick up if ba na le tlhokwana ya HIV, gore ba khona o link to treatment. Again? Usually, the other one ke gore re bone and we've been struggling with this age group. Bana ba rena ba 15 to 24 years. Ba khumana HIV. The new cases tsa HIV tse dintsi di diragala between 15 to 24 years. Jwale in this particular financial year, ye re reportang ka ona, re bone di ile fase ganyane. Mara e sa le concern ka gore really re need go le re thusheng le yena jwale ka community gore bana ba e sa le ba banyane kudu gore ba ka ba exposed to these things. Both and a miracle as wa health fela. Thuto ya ithoma ka mo gae ka motswadi le ko sekolong le rena re kgone go ya re kgone ba ruta ka tsona dilotse re bone decline in terms of the strategies and one of the things that we thusha ke gore we have made our facilities youth friendly. So era gore ga ba etla ba nyoka go tlo access di condom bana ba rena ba bashimane, they can now come. And I never saw a judge or ever it like a Manasana ba train or Ascaba level Labarushaka condomo Nivian. Like one? Okay, Rikitelepe. Ribone ore, but what about Tushaka, what we call ART child remaining in care. Eringate saying, Vana between the ages of 0 and 15, Bobali HIV, Rababia on treatment, and Bakumana HIV through different processes. Again? Ya mathomo e ka no ba mother to child, ge mosadi a imile, then I transfer to ngwana. Again? So we have seen really a decline in terms of making sure hore bana ba batla go facilitating ra kgona go ba fa dipilisi tša gore ba kgone go dinwa, and that is how we measure remaining in care. Mara le tla e bona ke tlo e tlhalosa. We are struggling to make sure hore bana ba virally suppressed. He ke re virally suppressed ke gore gape ge o tlile o le motswadi o tlisitse ngwana re o fa dipilisi, ga se o re ngwana o mo fa dipilisi. So ke responsibility ya guardian ya ngwana gore a make sure gore ge re seno mo fa pilisi re pilisi ke tša ngwana o mo fa so le so le so, a fe ngwana o dipilisi tšeuwe ka mokgwa wo re mo di recommendileng ka gona. Ke yone ya o dira gore bolwetse bo mo ngwaneng bo ya fase bo be under control. So we are struggling to make sure they are virally suppressed. Very suppressed ra gore virus ela ye santse gore e be controlled ka dipilisi tšeuwe, ga e be controlled. Because batswadi ba rena ga ba fe ngwana dipilisi ka mokgwa wa tshwanelo, ka mokgwa o recommendilwego ka gona. La e bona? So re kgopela help ka setšhaba gore re thušeng in that particular process gore bana ba kgone ba suppressed. Okay, ke tlo bolela ka TB. So TB, re bone an improvement ka what we call a TB treatment success. And which means also the TB treatment death. TB, ga e sa bolaya. Again, as long as there's no medication about this medication, you drink it for 6 months, when now you stick to that particular treatment, and then you end up having what we call a TB treatment success rate. And ultimately, death, ka lebaka la TB, di a fase ka lebaka la gore batho ba bantši ba go ba e le goreng ba khumane pholo ka lebaka la dipilisi re fileng tšona, re kgona go ba bona jwale. La e bona? The last one, ke nyaka go boela morago ya HIV, is what we call infant PCR test positive around 6 months. And I think this is very much, we only have 0.3%. E ra gore transmission ya HIV positive from mother to child e ile fase, and re bona decrease year on year. La e bona? Ultimately ga re sa nyaka go bona this particular bana ba o tswala bana le HIV ka gore now ke di-methods tse dintsi tša e le goreng re kgona go di šomiša go prevent. One of them ke gore ge motswadi a etla a imile ka pela, a etla before 20 weeks, re kgona go mo initiator, re kgona mo mea on prepo e thuša ka go preventa mother to child transmission. Jwale la e bona gore ge o ka re o tsebile gore o imile, wa make sure o ya ko facilitating on time, wa thoma ka di ANC classes tša gago, a wa re ka kgona o e manage tabai. Re ko make sure we have got 0 mother to child HIV transmission. Again? Oho. Re go tšwele pele. All right. So in terms of administration, I did mention where we are struggling in this particular department, and we managed to do well. Did medical legal. Those incidences that happens in our facilities, we end up but I had this problem, and then Basua department, we want a huge decline over the years in terms of the incidents as well as in terms of those medical legals. And as you can see, back in the previous financial year, it was 13 billion. And how na budget ya chon? Era go santse re nyake budget elsewhere ho re make sure hore re settle this ones. So jwale re bone decrease in terms of this, and they have went out dramatically. Because we have implemented a strategy where those dormant matters, the archive, also na le process ya mediation re following. Ye le gore re kgona settle easier, and these matters are able to be controlled. Okay. The next one is the ideal. And the ideal ke follow up just to ensure facility enough basic equipment. How you got clinic in there is basic equipment, only emergency trolley. In terms of emergencies, we can this trolley to respond to your emergency. So we want an improvement from in this particular area as well. The other area is school health. School health is very important, colleagues, because we make sure we integrate the Department of Education, the nurses, chahoya, what do you call di kgone screena bana ba banyane ba ile goreng re ba message ene ha batle ko facility re kgone ba immunizer re kgone ba screena. So all these particular programs they follow and re bona year on year re bona an increase in terms of these particular processes just the following to make sure we reach more and more kids re ba screening and re ba fang this kind of education. E reng ke bolleng ka di ambulance. The ambulance tsa rena re di measure ka mgo. Ge o le ko community o founa o nyaka ambulance o le in an urban area. Re time from the time that particular call is received to the level where you are in a facility, in 30 minutes, we are able to take you from the community, link to the nearest facility, ka ambulance. So, we want to increase and improvement as a department because we've implemented other people. We've got now interns, we've got this particular process, and they've increased in terms of this process. The linking to care even improved for you from where you have called to the nearest facility. If you are in a rural area, it's for us to get you there within an hour. Where medically re bitsang hore ke golden hour. So golden hour era hore batho ba na le a better chance ya go receive bophelo and less chance of dying. Ge ile gore re kgona go ba tšea from where they request assistance to the facility gore ba kgone o bona clinician ya bona ya mathomo within an hour. Ba na le chance ya bophelo ge ile gore all these things we can do them within an hour. So we want improvement in terms of our response to the needs in as much as the ambulances are concerned. Mental health. Mental health, one of the things, and this is one of the most imaging priorities that are happening, and they're becoming a pandemic actually. So as the Department of Health, in our district hospitals, in our regional hospitals, we dedicate section the hospital for the emergent cases of mental health. Mental health case. To your nearest facility, specialized. We make sure these services, emergency, acute mental health, beds are reserved specifically for John. All right. Still on mental health, we have now been making sure in our clinics, our mental health patients have access treatment. And we are also working on the CCMDD, mental health patients have access treatment within the CCMDD platform. Make sure how cure facility we medication. Once you stable, we enroll, we have got Lixi, we have got this game. Once you enrolled to access your medication. Again? All right. Yeah, let's let some fellows the areas where we are doing well. There are some areas where we are not doing well as well that I will highlight. So, in terms of our training, program 60, it trains my nurse. Advertised, I think it was last month. It is the new intake here, the nursing students. So we have seen, we've reached our targets in terms of that. As well as to a new intake in terms of our EMS. To say, who about 12 number driver the ambulance. We have a trainer, Lebona. We have a train you on this program, and then ultimately, the staff Sarena. So the ambulance, so by equipped, manager, emergency. So that we have seen as well an improvement in terms of that. One of the things that we also do, we've got staff members as well. I get that is employed. And we have a capacitator, so we have got a bursary process where we say internal staff members, heavily employed, we offer bursary, or we capacitated. But we study further. The disease, they evolve with time. So those that want to super specialize, they want to deal with new emergencies, new pandemics. Those that are lacking in management, and we've seen the increase in terms of that. Pharmaceutical services, program 7. Make sure the medicine di facilitating terrain. So this particular program, we want an increase in terms of ensuring the patients enroll on this CCMDD. They are good. Gape enroll on CCMDD. Era o stable. Ora treatment on time. So in terms of those that are taking their treatment on time for their chronic, for their hypertension, for their diabetes, for their HIV, we have seen an increase in terms of that. Hence, an increase in terms of the enrollment on the CCMDD. However, na le challenge community. Challenge ke hore re enrolla batho on CCMDD re botsa hore wena from now on o your medication ya how got clicks a so. And the committee members don't go there to collect their treatment anymore. So it's what we call activeness on the program. That is the challenge. Understood? Okay, let me move on to the next slide. The next slide, our disease prevention. And on this one, give me 1 second. All right, okay. On this program, Gauteng gasi area ya malaria. It's not a malaria endemic area. But we have really seen more death of people that are dying because of malaria. And this is because these people are not seeking care earlier when they have these symptoms. So they present late in our facilities. So this idiragore repalele mostly to manage them because they will come with complications when they come to our facilities. Again? So, usually, can you go over mother and child? Can you put a more struggle on horn? So the struggle mostly vaccination. In terms of vaccination, we have struggles in terms of measles and vaccination for under 1. And some of these things, but banana road to health card. Again, road to health card is specify this is the routine one now at the vaccination leaning. Again, je le re khopela le thuso ya lena batswadi hore bana ba nko le batliseng ko facility ka nako gore ba kgone ho vaccinate wa ka nako. Again, so we even went on what we call a campaign, measles, because there is an outbreak. So we are on a campaign just to make sure we recover more kids and we prevent them from contracting this particular measles. We have also struggled in terms of the SEM. SEM is what we call severe acute malnutrition. Ke bana ba le ba ile goreng ba na le phepo ye enough. Dijo tse ba di jago ga di na phepo. Jole re bone bana ba ile goreng ba tlhokofetse ka lebaka la go tlhoka dijo tsa go ba le phepo. Jole community, please, there are basic nutrition requirements that are required. And also our social development colleagues are assisting us to make sure those food parcels are received. At least the food parcels this particular process. I also want to speak about the facility governance. And one of the things they are struggling with the hospital boards. So hospital boards, get the board members to each hospital to make sure our CEOs, our performance of the hospital, they remain accountable. And is made up of the community members. The same with the clinic committees. So we've seen quite a lot of resignations. We can meet our targets in terms of the activeness of this. So please, when you are appointed as a clinic committee member, assist us or make us sure this committee, the clinic, and you are the bridge between the community and the facility. So all the needs of the community, the address at a very high level has to struggle. Come make sure the adults, and the adults they struggle mostly. Banna battle to facilities, battle nyaka care. Even if vale HIV positive, initiated on treatment, re a struggle hore re ba khumane hore ba tle ba tlo khumana treatment hore ba be stable. Hape ha o se stable e ra hore o ka infecta ba bangwe. Ha ke re o be on treatment or be on treatment hore o be le ntho ba re ke virally suppressed. Once o le virally suppressed e ra hore chance ya hao ya hore o infect someone else e ba fase. So banna ba leng ka mo building ka mo ke nyaka bona le ya kwa le low screen e re tloa. Okay, ye nngwe ke bana hore ba be virally suppressed, and the caregiver ke boletša ka yona briefly ka re ba tla ba tša medication. And re a ba botša hore medication o fa jwale wa fa ngwana jwale wa fa ngwana jwale. Mara still re bona bana ba sa suppress. Ge e le gore wa lebala e seta nako ya gago medication o very straightforward wa suppression tsa nako ya gago tse bore nna every single time ka 6 a.m. Sata alarm more ke fa ngwana medication ka 7 a.m. or later ka 7 p.m. What's about every day o fa ngwana this medication? Gore viral load mo ngwaneng e fase ngwana a kgone go ba normal, a kgone go tsamaya a re lokele bana ba bangwe mo strateng a se ka a lwala. Letsoalo. In terms of our ambulances, and this is where we also need your assistance, community. The ambulances are rena ge di tla mo community, di a hijackiwa. The ambulance arena, but it's for a lack of a better word. We have got what we call hotspot areas. These are areas whereby even our ambulance personnel ba panic. Remember, about America law enforcement, about America di polika ka mapodisa gere. So, ra le khopela ho le re thushe le rena hore our community policing forums le kgona hore thusha hore he di ambulance di tla le kgona make awareness gore batho ba founela ba re ke na le problem mo le mo he ba ya ka a se problem ke scam bo hijacking re khopela that intervention gore a re bereke mmogo go le kgona hore thusha gore ge ba etla kwa ba ska ba hijackiwa. One of the issues that we also struggle with, but this is something that we are prioritizing, what we call an inter-facility transfer. Ge we ile wanyaka di services ko facility ko clinicing bara awa ka mogoleng ka gona e re o refer gore o ye ko sepetlele gore o khumana thusho and ba tja ambulance e tla e tlo tja yo isha kwa. We're struggling to meet our targets gore o fitlisha kwa ka nako o kgone o khumana care ka nako. Because emergency sections are triaging as well. Mara now, the ambulance in our facilities, or they get first preference, but then we linked to care, but one clinician. We have got quite a few problems that we have faced in terms of administration, which is that very first program ye ke boletseng ka gona. Ye nngwe ke gore e make sure gore a percentage ya budget ya rena ye re e beileng for procurement ia to township development. So one of the township development ke gore the company tse le goreng di tswa ko townshipong di kgone khumana di contract re be di supplier tsa department. We are not doing well in that area. So what we are doing now, una le list e le goreng e bontsha di company tse le goreng ke di ko township. So that list is circulated to our facilities every month gore ba kgone gore he ba compete e be le le ba di township enterprises ba kgone compete gore ba kgone provide the services as suppliers to the department. The other one ke go make sure gore our senior managers e ba basadi. A ke santse re manager 50-50. It's kind of a banna fela ba ile goreng ba mo senior management positions. So that's now we have advertised certain positions le bone the advert di tswile, and then we are going to be preferring women in some of those management positions. So we encourage women, when you see these positions being advertised, our CEO positions, our director, our chief director positions, apply yang. Gore le kgone compete, le na re kgone ho raowa, re leader ke basadi. Akere ba re who runs the world? Okay. Re nke tsweleng pele. Ye nngwe re struggling ka yona ke ya ho make sure gore the invoice tsa rena re di patela within 30 days. This is the mandate, ya treasury mandate, ya province. Mara, we have implemented measures here to make sure those invoices, which are the disputes, completed properly, you have rendered a service to the department, and then you have submitted your invoices, now we must pay you. So the department has set the target here, in 30 days, you must have the money. The staff members, company how is kaya. So we've now implemented measures to make sure those purchase orders, demo systeming for 2 months. And make sure we hold our facilities accountable. Once a service is done, submit an invoice in advance. And we want to increase in terms of that. As of Q2, we were sitting at about above 75%. We make 100% of this one. We make sure we implement them on time. Okay. The other ones that we have been struggling with is the ICT. And ICT, our facilities, one patient, one file. An electronic system where you facilitating no press as well. Happen to process manually ya kumana batacha the register manually batacha patient file manually. It's yana ko agere. So if palakele ono rabano vale tablet bano khota mo and then ba refer o ye ka mo bano khota mo hey lo ro nya tshere ke ambulance wile ba refer ile to a district hospital he o fitla kwa ba bule tablet ba bona oh ko facility nyela ba dirile 1 2 3 4 5 ba tswele pele from there. All these things can be possible hey le gore we implement one patient one file strategy. So we have been struggling in that department, but measures have been put in place at our CHC levels now. We have more CHCs. Oh yeah, the tablet now. The hospital levels, now they are doing that. So we are speeding up that process to ensure we have developed a strategy to ensure we improve in that area. I think the last slide on this one is when we spoke about quality assurance. And I can tell us a little bit this one as well. In terms of quality assurance, we are measuring certain things. I get a local facilitating, hey Lord, our happy car service. We've got what we call complaints. Again, you issue out a complaint and then you put it there. So we've seen a decline in terms of the number of complaints that we receive year on year. However, we are struggling to resolve these complaints because the policy department, the guideline, we relay our complaining department within 25 working days. This complaint is resolved. And one of the critical steps that we need to resolve that complaint is for this complainant here tsamaile abuye re tlo ba le nto ya batho we call a redress. Re nne as a facility re redress this particular complaint, re resolve le wena o be satisfied e tswalele that complaint. So our community members re a tla re a gopela gore ge le na le di-complaints e tlang e ba le founela re feng di-number tse di right ba le founela e tlang ko facility re kgona o e sorta out complain e le issuileng akere e kgona go ba resolved o re le wena o kgona go ba happy akere. Also, to try and mitigate this area, our MEC is launching what we call MEC's desk in facilities. This is where your complaints are going to be addressed by our MEC. So we take you guys very, very, very seriously in that particular regard. The other one is to make sure those incidents that are done, that we experience in facilities, they are resolved and they are closed as well. So come there, let's discuss, let's make sure we investigate that particular complaint and then we close it. Again, I will just summarize this one in terms of the mitigating. Mitigating, I'll talk about some of these areas. So I spoke about the different programs. What I want to also speak about is our infrastructure. We've made quite good progress in terms of our infrastructure. These are the capital projects, the refurbishment that we do in facilities, to make sure our hospitals are attractive. So we have been struggling to make sure we've got a new facility now that we are trying to finalize. But this financial year, we are on track to ensure we finalize. This is a CHC in the Randfontein area, Randfontein CHC, and we really want to make sure we finalize the particular facility. So community members, this is the status of the Department of Health. I am requesting you where areas where we struggle, it's not only our efforts that achieve. Most of this, we deliver services to you. So please bring the kids. Give them the medication. Men seek help. When our ambulances come there, assist us in ensuring that these ambulances, they get the right care. When we say we are screening and we are targeting, we're having these particular areas, present. Let us screen. Let's make sure that you get linked to care. Together we can do it all. And thank you so much.
Is there anything?
No. Thank you very much, Mr. Ngwepe. Bagaitso, that was the presentation. Yarona will then hand over back to the chairperson.
You are 21. 21 times 2 ke bokae? 42 minutes. La utlwa just ka 2 minutes tsa sebaka se se kana. So I reckon 3 minutes. La bona re ya tlola gore e feta le na kwa lunch. Again. So ke batlo re lona ra agreeing, ke batlo gore ke impose. Are we comfortable with 2 minutes? Ai ke batlo akere ke nna mo MMC mo. Mo ke nna re tlile mo setšhabeng setšhaba tshwantse re se fe sebaka akere. Ara tshwa no fela pele. Are we okay with 2 minutes or you want 3 minutes? O agree with 2 minutes. Ra dumellana ke re baholo. Ke yona ntho e re bitsang social compacting. Akere. So re tlo simolla ka number 1 ya rona. Wa itse re ke tlo kopa eng? I can see how practical it will be. I don't know the problem. Mara ke tsele ditulo bona. Ne ke re ba rona ba le 12, ditulo ke tsele mo. There are 2, 4, 6, 8, 9 chairs. And then 3. So they are kopane. If you can take those chairs, to ba le ba re ba supile mbale ba tle mo pele, akere, the 12. Ka yona lenaneo lele. You will see it's going to work a lot quick. Akere. And then le tlo utlwa ko etsa ala mtloko akere a ke batlo nna rutu ke ke emela ke re o feditse ha o utlwa e lala mo itse gore e chaila akere ro fa fela grace nyana ya less than motsotswana gore o feleletse akere ditulo tse ding ke tse le mole ai ba di tseye ba di tlise mo whichever way
Number 3, lo.
It's a fella banne. Baholo ba ba tlo buang le gono bua ka puo e nngwe le nngwe akere le ska tshoa la kra ile re tshwantse le feel gore o tshwantse o ka sekgowa or in any language akere you can express yourself in any language e re ke etsa bjang ona le maikomo a re simolleng ka number 1 ya rona akere
Molweni bahlali. Igama lam ndingubuyisiwe Sigonyela. I'm from Sibei Mutweneng Clinic in Zone 12. Tina challenges esinazo sine challenges ze-ambulance. Umntu xa efikile kufuneka kwi-facility yethu kufuneka aye esibhedlele. It takes long umntu agqibele seke ngada angafikanga esibhedlele. I'm saying that because I brought my father last week and it happened that uye wathatha the whole day. That and that nayi ulambile ngoku ku 4 o'clock makabuyele ekhaya. So we couldn't get that help. Another one, leyo kuti ambulance xa uyibizile it should take 30 minutes.
Kana ke mmema mvuyisi
Buyisiwe.
Okay. Why is it kopang? When you explain maybe a concern, a problem, try to be as detailed. Tell us about which facility. If it's a clinic, tell us, or if it's a hospital, which one, so that we are clear. Again.
I've said that. Didn't that say Sibei Mutweneng Clinic? Sibei Mutweneng. It's in Zone 12. It's in Sebokeng, yes. So another problem that we are facing, Tina, Uguti, if you sinama complaints, we do as CHCs attend to them, and then our complaints shem siyakwazi solve and siyabonga ngoba abantu nabethu bas improve le clinic ethu ukuthi bajabulile improvement ikhona. So now esicela ile 30 minutes endive ubhuti ethetha uba iambulance it should take 30 minutes. Hayi thina apha asinayo eGauteng. Andazi okanye ndiyaxoka na umuntu ubiza iambulance namhlanje ebusuku ifike ngomso late. Thank you.
All right, thank you very much. Let's take number 2. Let's take number 2.
Ngutamsanqa Mkhiwane Thami from Zone 14 Clinic, Ward 31. The challenge facility yethu, the councillors, abanama offices, it is a challenge during rain. It also, winter, it's a problem. There were 2 councillors who passed on in that situation. So siyacela ke because MEC walapha MMC West Dibing makahamba check at that situation and then also the clinic in Ncinci, and then also the challenge, your staff members. We can't, in fact, the staff members reach a target, long waiting period within the facility. It takes long. That is those the challenges. Zone 14 clinic.
Zone 14.
Yes. Pela Chisanyam. Thank you. Lastly, in terms of the report, I see there are vacant posts in the material posts and that are open. But what about the staff members? Because there's short staff members in our facilities. Debulel.
Thank you very much. And that Tamsang, lawyer no tusi zeganako.
Okay.
Arze number 3.
Okay, lika libua le Mashudu Msimanga ke tswa zone 13. Na concern ya ka ke clinic ya rona ya zone 13. E re ke re ke bua ka staff sa teng.
Ara utlwa lebitso la hao.
Ke Mashudu Msimanga ke tswa zone 13. So ke tlo bua ka clinic ya zone 13. Bed service. And then in staff sa teng ha sena botho. Not all of them, but asena botho. Ki khutle ke tle zone 17 clinic. Di file di phela di nyametse. So ke dumelana le papa hanare ho tshintshwe method. Ya hore iska hlotse ba di file ha o admituwe o ile clinicing o tlo ya sepetlele e etse ka di tablets because di phela di nyametse each and everything. And then ha o bua le sona staff sa teng wa chikuwa o tshaba le bua o tshaba le botsa. Ke a leboha.
Alright, Chair, ke Mishak Mtibedi from Johandio or Puluku. Number one, ke rata, in fact, every time when I see MEC Nomantu Ralehoko, I become inspired because she once helped me in the middle of the night when I give her a WhatsApp message because I was in distress for a diabetic type of a situation, and a manager who was supposed to order correct medication on time failed to do so. And the intervention of the MEC helped the situation. It is for that reason that I'm saying that as long as I see her, I will forever cherish her throughout my life. Thank you so much. The second point is around the publicity, the negative publicity around health department in Gauteng. I'm making an appeal to the executive, to the operators, to the managers. What we saw yesterday at night around this program called Moja Love is in the bad taste. How can a wall costing the department 20 million rand go unnoticed? Surely, certain things have to be done. Kindly please change the perception. Change that. It cannot be correct. A 20 million rand, which was supposed meant for a clinic, turned out to be just a wall without responsibility. Please take it into your confidence so that we don't believe what has been presented yesterday. Lastly, Kopanong Hospital. Kopanong Hospital is a mess. Can the Department of Health change this narrative? It's in a bad taste. Thank you so much.
Thank you very much. Let's take number 5. Marawara Talusesa, what are your observations about Kopanong? Because when you say it's a mess, it's a sweeping statement.
Sweeping statement. My apology, I thought that is well known. Kopanong Hospital, in fact, certain contractors have been given during the time of the former MEC, Public Works, Tasmin Motara. Quite a number of local contractors has been given a tender to construct, to renovate, and to do other things in Kopanong. To date, the area is still the same. And I'm wondering, the monitoring and evaluation, before you pay out, surely there was supposed to be a monitoring evaluation before you pay, because the the situation and conditions still the same. It also invite me to raise the area where I'm living, Johandio. Johandio has a 6,478 a population servicing other areas nearby, 5 of them. And really the staff cannot take it anymore. And I'm appealing to be given a petition because I want to do this formally. To say we are appealing for a 24-hour service to Handio Clinic.
Okay.
Thank you.
Okay. All right. Number 5.
Sanbonani Bashal, William Ngonelo from Ward 6.
Ma?
William Ngonelo from Ward 6, Mfulweni. Chair, I have two of my questions that I would like to get assistance from. Unfortunately, they are off the points of agenda. One point, I'm here by asking for assistance. I've been in communication with Gauteng provincial legislator, requesting for participation of inviting an official of Gauteng provincial legislator to come into our stakeholders meeting in November with South African Human Rights Commission, a public protector, CDBN Speaker's Office, and as well, we see to our interest that Gauteng provincial legislator will help with regards. The reason, I think the one who's designated to deal with issues Mfulweni, Prince Kubek, but it's either not responsive or he doesn't care, I don't know.
Yeah, wait a minute.
Thank you. Can,
and then we'll facilitate. Ne?
no, matata rona
Le
ke,
nna nka nna ka tla, o batla ke tle.
okay, matata rona, we avoid situation ya hore ha le tla as portfolio committee to give us 2 minutes and mohlomong o tla ha iwane frena gen. Therefore, at least with engagement of inviting stakeholders so then you can get proper
Ke
perspective.
dumelana le wena, o tle ke re nna.
Okay.
Ke available hore ke tle. Ha o mpiditse.
So I'll jump to the second question of assistance. The second question ke abuti qetang ho bua ka yona, can portfolio committee assist in this regards? We avoid approach as unsustainable kapa as non-resolution. There's this thing where government IDP reflect the project and they are empowered to make sure they develop about economical. But similar project a provincial competency, school, clinic, and etc. provincial or local. They are either never finished, but the money has been put into the project. Therefore, our proposal, instead of going the route of petition, because petition committee, you will find they will somehow respond to you after 5 years. Can we then at least have members of a committee that is responsible for infrastructure to monitor project it's a question? As we speak, renal project it's a tool question in Zaron. It's a fella. And we come after 5 years to IDP, repromise you or clinic high fail. Repromise you that cannot be sustainable. Next time we have a solution. So then we cluster and make sure we take Gauteng forward. We are out.
Can you name the projects?
Abuti,
Can you name the projects that you
yes,
mentioned?
please, that's what I
Okay,
wanted to say.
the first project is upgrading of the informal settlement in Ward 6, Grisahani. Project is kadile main contract it's EM. So probably mhlang go khutlang hona lona tabelena le a detailed report of what is happening. The same project it excluded same project. Only informal settlement of household that are 100. But
my brother.
I hear you.
What's
But
informal
Miss-
settlement di door palla,
Okay.
because ki committee is different, ki department is different. So nerna nor me butla bua motlhomong ka project e shebaneng le a clinic, a hospital, or any such rehabilitation center, Marano I
Over and
informal
out,
settlement di door palla,
Over and out. Maybe then you will assist on giving reference or who do we talk to?
Yeah.
Who's the relevant portfolio for us going forward?
We will share with you the contact details of the relevant persons. Marbo, bozo, bozo, bozo. I get urlot la invite. Utla on invite ne.
I'll wait for your response.
Na na ke available on invite ne.
Oh, Bopilong primary. Bopilong.
Ke tlhalle ne.
Meeting wa rona will be on the 28th of November. Which
Utla ntswara ka bela sa ke.
okay, can you get the phone number from where because we are meeting ile.
Dai au tutla over number ga. Na ho. Ra over number go ntshwara. Are ngo number 6.
Yeah, Kalau Dumedisa, Program Director. Thank you, ka report re thotseng ka leboha le mo our government province a rona re phile report ya Gauteng. Firstly, bitso la ka ke Lawrence Majoro, I'm
Why is
coming.
it there ara utlwa le bitso la
Ke tlo bua ka lona. Ke re firstly bitso la ka ke Lawrence Majoro, that is what I say. Ke Lawrence Majoro ke dula ko rural ke tswa ko Ward 25. Actually ke batla qala ka hae pele. I'm talking about for forgettable community. Tsa di rural. Ke a utlwa di report ya hlaya but ha ona mo reng Gauteng province clinic di rural e tlo etsa 1 2 3. I'm talking ke bua tjena e le re na le concern ke re na le clinic tse ka bang di 7 ka ra ward. Rural mo e leng di mobile clinic. Those people ba di rural ha ba thole services from department ina ya lona ya health. But di clinic tse tsa di mobile tse di tla nako tsa bona ho etsalang ke issue tse teng tsona tseo. Re na le clinic ba re ke respirate e le hore maybe ke yona e kgolo ka hara di rural. E le hore e service batho ba 890 per year. Ena le challenge tse leng ka hara yona ha ena staff sa teng ke batho ba 7 e leng di PAC E1 1 facilitate manager staff nurse A1 be ba professional nurse 3. Just imagine motho a E1 ka suka msebi, that's a challenge. Issue ngwe ke batla ho tla yona ke ha clinic I'm talking ka issue e leng e personal leadership le nna maobane. Ke na le ngwana e leng go bua sign language wa kula. Ba mo referetse ko clinic ko nthong ko kopanong ko hospital. I went there to hospital for service ya tlameleng go e thola. O tla e thola next year ka March ka di 3. Just imagine motho wa kula ona di pain batho ba go yena o tlo thola service yo tlameleng go e thola next year ka 2026 ka di 3 tsa March. Ho etsahalang phirotwe kaofela. Other issue e batlang go tlhaisa ke batla ho tseba department ya utlwa le be
Ke go efeng which facility is that one?
respirate primary health care eco respirate clinic ba mo referetse ko Sebokeng o thotse data appointment maobane. Other issue ke batlang ho e raise ke ya hore department ke ya bona e recruiter di EPWP. You're talking about the training and development to develop batho bana. Mara our EPWP they are not developed. Even in your program, I can't tell you what to know. When I EPWP tse teng ka hara department ya rona ya health, re tlo ba fa di skills after na go kana ha ba tswe ba tseba ba kgone hore ba develop ha iyo that report. As last time on the EPWP they went to office ya MEC. Ba loto itoya ba lo gale ba hiruwe ba nka nako ka di EPWP ka hara office. Because if motho aka ile EPWP ya banka 3 years. Unfortunately, ke nana sentse le part of deployment. Yo tlamile go twa deploy. Le mo hoi level e fona kwe kalo. Ke nako ta ke utlwa the last issue ke ya golden hour. It's awesome now. You are talking about golden hour ambulance, sitting at golden hour. But unfortunately, the ambulance, go clinic, go John Hayes. John Hayes, the ambulance, the trades garage rate. How na the driver? Wow, phone, there is no ambulance, but you are talking a nice language, golden hour, whatever, but into the last one. Yeah, ya o qetela senda tore. The last one. Ke batla ho tsaya utlwa ho thwe ho na di resignation sa di clinic committee. If you went to the clinics, you told the clinic committee they resign just because I did told that capacity. Thank you.
Lebohile again. Artse number 7.
Ke lebohile motsamaisi wa mosebetsi. Ke Lipule Mokoena ke hla ward 25 e leng Johandia. Nna ntho e ke leng concern haholo ka yone e le horeng ha ke kgone ka utlwisisa and e lematsang rona re le community. Ambulance ke founela ambulance ya tla e tlo nka nna. Inyisa mara what about nna ke tsamaya ke ile ka public transport. Motho ola ba tlo thola service e le hore le nna o tlo thola yona. Ha ke kgone ena le sense ntwe. Ha ba thuse batho be le hore o ile ka public ke tsuile o seng ka 4 o'clock o kilo fola man. Mara motho ambulance o ntlo mposta o fitla mo. Ke kopa o ilukise MMC ke lebohile.
Bona ndate John. O itse a re nya go re tsamaya mo re sa tlhalwanya.
Okay.
O lla ka dilo tsa ambulance.
Kore ho thwe ambulance ha yo latile o le mokudi a kere. Nna ke tsuile o seng ka transport ya public ke a clinic. So motho a tlileng ka ambulance o kgona ho tlo mposta mara nna ntse ke le line. Ho tshore nna ditulo mona batho ba ile hore ba fotse mona ba phesha ka ditulo. Ha ba betere hona le motho a etsang a tlang ka ambulance.
Oh, so ba batlileng ka ambulance ba le tsenella. Is that what you're saying?
Ke moetapele wa ka.
Oh, no, but I respond there, like no problem.
Okay, thank you, Mre.
All right.
Good morning. My name is Zolile Nyembe from Ratanda Clinic in Letsoalo.
Ya simolla starta ko mathomo o le bitso ra utla.
Okay. Good morning. My name is Zolile Nyembe from Ratanda in Letsoalo municipality.
Bozo, a re utlwi le bitso la hao. O re ke mang?
Zolile Nyembe. Yes. I've got 2 questions with regards to Ratanda main clinic of the staff and the negligence of staffs that couldn't take care of the patients in the clinic. The main problem is people who are not feeling well, who wants to come to clinic. At the end of the day, there's no staff. The staff is busy, lazing around, and people were complaining at Ratanda main clinic. 2 months ago, people were toy-toying due to the negligence of the staff who refused to help the patients in the clinic. Second question, young people were overdosed of drugs. They were doing drugs at school, and teachers were not paying attention to the students due to drug problems. Thank you, sir. Yes.
Is this what you will have observed?
Yes.
If so, when did you observe it? And where? Are you saying Ratanda Clinic?
Yes. And then I also observe it at school.
At school?
Also.
Or at school also. So when you say there are youth who are being overdrugged, who are those? Who are you talking about?
The young kids.
They are being overdrugged how?
They were smoking glue. They were smoking glue
Oh, so they were taken to hospital, I mean to the clinic.
to the clinic.
Oh, okay, from school.
Yes.
All right. Okay.
Yes.
All right, no, we get you. Thank you so much. So the teachers were negligent. These kids were taken to hospital, having been overdrugged. I wanted to connect that story. Let's take number 9.
Sanibonani. Ngiqala ukubingelela abavakashi bethu abasivakashele namhlanje. MEC kanye nahamba nabo kwehla njalo ngezihlalo zabo. Ngiphinde ngibingelele ne-steering committee esisimele khona la endaweni yaseSidibeng. Ibizo ke lami ke mina ngoThulani wakanyembi Sibongo. Ngu-chairperson we-main clinic yaseRathanda, eHeidelberg under iLisedi. Ngithanda ukubonga leli thuba ke nami lokuma phambi kwenu ngizodalula udaba olusihlupha kakhulu. Ake ngiqale ngomfethu uNyembo oqeda kusuka. Mhlambe make khuluma ngeoverdose. One challenge esinayo, there's a transport eqhamuka from the Department of Health. Distributor ama needles. Distributor le into le ingane ezihlaba ngazo. Iyatholakala siyithola extension 23 inokuma lapho leyo transport. So it becomes a challenge kakhulu ukuthi while kuliwa nama drug but futhi department yethu ye health iphinde futhi yona iprovide ngama injections. Ngicabanga ukuthi bengisafuna ukulungisa lokho kuqala. Right, okwesibili ke okuyimbuzo yami nami ngizoshesha njengibe mfishane njengesikhindisa ngaphansi. Okokuqala I stand being corrected. Kungenzeka mhlambe lembuzo engizobuza awuhambiselani nale nkundla namhlanje. Okokuqala engifuna ukwazi ukuthi iDepartment of Health izoqala nini mhlambe ukuthi ibe nezindawo zayo rather than ukuthi isose indawo under umasipala. Ngoba leyo nto iyasilimaza makufuneke ku renovate noma kukhuliswe iclinic njenge clinic yaseRathanda ngakukhuliswa kodwa ngenxa yendawo ekuyo ebelonga kumasipala it becomes a challenge. Okwesibili ngizongena kwi shortage of staff. Yazi engathanda ukusho kubaphathi bethu ukuthi cha inhliziyo zenu ziyabanda. Ngoba nina nithathe abantwana babantu nabayise ezikoleni bafunda baba qualified baniqeda nazobasebenzisa abashoda. Especially eclinic le ngiqhamuka kuyona kune challenge ukuthi sinendawo entsha ekhulayo which is called Orbit Nkosi. Le ndawo ekhulayo eyi-Orbit Nkosi, now it creates a problem and a challenge ku main clinic because abantu balapho sekumele bonke bazophelela khona la ku Rathanda main clinic. That becomes a problem. Sister abasizayo nabo bayakhathala ngenxa yomsebenzi omningi asebenawo.
All right. 2 minutes ifikile.
Okay, ngicela nje ukuyirapha Nkosi yami. Bengisadla inkondlo. Okay.
Less than a minute.
Ngicela nisedeleni ambulance eRathanda. Rathanda is divided kanjena kune area abayibiza Devon which is 50 km away from main clinic from eRathanda. Meaningly ama ambulance aba challenge maswadinga afike emva kwesikhathi. Okugcina futhi ke
Thank you very much my brother. Thank you so much.
Ubhlungu nje manje ngivala ngoba bengisafuna ukuphawula.
Before you leave,
angazi noma
Babtulani.
ngiphendule ngoba sengithulisiwe mama noma ngenze njani.
Before you leave, Babtulani. Uthi kunemoto.
Yebo mama
Awukangangizwa ukuthi ngithini.
Yes.
Kunemoto ye health department. Eza ima at a particular spot, it distributor ama needles. Laba abantwana bazihlaba ngawo ngama drugs. What do you mean?
Sengaphendula.
And ungasipha i-registration yaleyo moto.
Oh I tried the registration anginayo kodwa
Awunayo.
ngayithola yona ngayithola.
So nuwumphakathi.
Yebo mama.
Babthula no.
Yebo.
Niwumphakathi. Niyayibona le moto. Probably in an emblem ye Department of Health. Ima emphakathini la sihlushwa khona ama drugs. It distributor ama needles. One asibazi labantu baleyo moto, asiwazi lama needles awani, but abantwana bethu baya collector bayithabaka injections ewu ba sebedisa di-drugs. Up until now, as we are standing here, you can't give us the registration of that car. So ingenile yayenza simoshela abantwana, siyayibukela yaphuma yahamba. Sayiyeka. Then uzoyireport lana. Mara asina evidence.
All right, sharp.
Ake
Wait.
bopha mphakathi.
Hello.
Bopha.
Hello. Baholo. Ake re rile ka mo. Re rile ke precinct ya legislature emapele ntate Thulane. Baholo. Re rile ke precinct ya eng ya legislature akere. A hona howling we are asking these questions because when the department responds, but respond factual akere. Because if you raise an issue in passing, your answer might also be in passing. But if you give the necessary detail, it enables us. There's criminality in them. We also want to liaise with the law enforcement agencies. If indeed there's a car to the Needle, say, around the Heidelberg or Ratanda, it might also be a criminal issue that needs to be reported. And that is why we're asking for further details around it. Again. So if you can, maybe just give that detail, if you have it. But if you don't want to do it openly, I think you can also come to us. If you know. If you don't know, it's okay, my brother.
Sengaphendula.
Ungaphendula.
Anginawo kwamanje lo mniningwane. Kodwa bekubalekile ukuthi nginivezele phela ukuthi nazi ukuthi kwenzakalani. Angeke ngisuke nje la ngisuka khona ngithwala ikhanda lami elikhulu ngize la ngizokhuluma into enjengale. Yingoba ngiyibonile ukuthi khona iyaphila. Yayibona.
All right, thank you very much. Thank you very much. Ere re tswalla pele akere. Mare re batlo le rotloetsa tsidi emambele. Motembo kwa ka o. A le tlo bua fela mo. Akere we must encourage you as the community. Or when you see wrong things happening, don't be bystanders. Don't be bystanders. There's so much that a department can do for you. But our government is a government of the people. This country was liberated by the people. So when you see acts of criminality, you don't turn a blind eye. You must report. You must popularize. I get it. If you share with somebody who might be courageous. Because if you don't do that, unfortunately, your communities are going to be ravaged by criminals. I get it. Because Lona, you will have chosen, or I were helpless. There's no such thing as a helpless community. So, Arzuel Lempe, number 10, Waron. I get it. Number 10.
Dumela matho ena ke radiepo kwa hamtau the concern ne ke na le yona hona le motho a ithatchiseng hanyana. I think I will just add on it ya kopano ke radiepo wa hamtau. So concern ne ke na le yona haholo ke ya kopano. Abutu e boletse mona in regard to the patient di dula nako e telele o thola hore ho attendwa batho ba di ambulance haholo. So my proposal on the regard is ntongwe hape ke actually ke le mohileng e ka re hona le bothata hape ba staff hobane ha ke observile Sebokeng le Kopano as much as Sebokeng sena le di patient tse ngata, but the service is better and faster than Kopano. And if maybe how ka etswa hore ke a tseba re tla re bitsa di ambulance because we think it is emergency and everything, and we are not good actually dinthong tsa bongaka. But I would suggest hore nthong e jwalo motho a assessiwe, then ha I see an agent, an agent, then at least ba lo reng khale ba dutse aba attendiwe. Because why it's about 4-5 ambulances. O tolere mostly dingaka boholo ba tsona di attenda batho bana. Batho ba tlo ema for more than 4 hours. By the time ba reng ba qala, ho so kena di ambulance tse ding. So I think it's a issue maybe ya staff, a bit of strategy to deal with the patients. Or the patient this case at 12 hours delay before they can attend you. Ya ho qetela, I just want the clarity in Kenya resource resource supplying. Kutlele ntate a bua mona hore there can be actually batho locationing by law and they can and all that. So take batlang ho e tseba kere, how do we get that info and what is needed for one to help so that the situation in dibakeng tsa rona. Thank you.
Re lebohile ntate Motau. A re tse number 11 wa rona.
Dumelang batswadi. MMC tsa rona ke a le dumedisa bohle ba teng ka go sebaka. Chairman, ke batla ba mokhutswane ka pelenyana. Taba tsa ka di ngata empa ke batla ba mokhutswane. Bo ntate taba la Kenville ntse ba e tlola.
A re start lona le tshaba mabitso a lona. La boela go tlase.
Ka lebitso ke Tukiso Mofokeng.
Ntate Mofokeng.
Ke tswa mo Ward 12. Ke na le dipotso tse ka banne. Ke batla di bula ka pelenyana hore ke kgone ho tloa nako se ka ngotla. Taba la Kenville ka COVID o tsile tšhelete e fuwa batho ba lo ba etse di room man Duncanville. So go motse ntse di eme di jolo ka morao ha di so lokiswe tšhelete e tswile batho ba so tshwara o so etsuwe nix. Ke number 1. And it's a second report to again happy. Rala ga report ka budget ya pele a ska wetsa la nix. So ke report hape ka budget ya bobedi hape no. Engwe ke ya ditliniking tsa borona re ema ka ntle le batswadi ba rona ba ema ka ntle pula di yana ba fotse di line ha ba etse di shelter nix ho ha. Ditliniking tsa borona di main clinic doctor e ba i1 e tla ka matsatsi. So ha etle every day. So re kopa re change be teng ho di MMC tsa rona. Hape Duncanville ho dula ho bloka di toilet each and every time. Ka ga di ward. I was one of them ne ke le mo le nna ka ward ke ka ward 7 e blokile. And re le batho ba nang le di sikisa tse leng ga di tshwane. Re dutse ka mo. Re sena toilet re sena fokol. Mare re tla di MMC re na di infrastructure ha ona ntho e tsegalang. Re kopa thuso. Re ya mo dipetlele re lo kopa thuso mare re bolawa ke dipetlele tsa borona. Ya ho qetela taba di ambulance di tla ka mora nako. Ke a tlatseletsa le nna. Re fana di ambulance ka mora nako. Engwe ke ya hore hape strate mo makula a donate a dinetlele se ho bana ba borona hore ba itlhabe hore se ke ba positive. Our government ke ena ba dumella hore ba donate because ba fa tšhelete. Ke a leboha.
Yeah, we shapile ka 2 minutes on the spot.
Dumelang batswadi.
Re tsa number 12 wa rona ke. Yeah, 12 a ke re ne re choose 12. Yeah. Unless o lo rona le tsotsana. It's in it. A ke re la bona ntshwene ke bu. Bona se se re na le 13 mara ra grile ka 12. So ko mo feng wa tsotsi tshwantse re mo sheba ke. Yeah. Are tse mama number 12.
Ka lebitso ke nna Mantombi wa Kgatebe ke hlaka wa 25 Johandiyo. Nna kopo ya ka ke clinic ya rona. Clinic ya rona e nyanye haholo le nako teng e nyanye. Lebaka ke lena ka nako ngwa ha o fitla clinicing meriana e fedile. Ntho e etsa hore meriana e fele ko hore polokong Johandiyo e senka dibaka tse ngata ho feta batho ba baahi ba dulang polokong. Ya bobedi ke doctor e tlang ka matsatsi hobane re na le bonkgono ba hloka hore doctor e ba bone ba ska ha fitla clinicing ba doctor e tla o sane nkgono tlamehile o tlile o sane ho le hore nkgono yana o kula hona jwale. Engwe hape e ke kopang hape ko re mobile clinic e ya meno re kopa e ska tla mhlang e batlang e dule e tla everyday hobane batho re tshware ke meno molebe re hloka ho ntsha meno ka nako ngwa re kgone ho ya Johandiyo kopo sepetlele sepetlele kopo Livambata. So clinic eo ya ke tsebe tlaneneng a ke tsebe lo re tla la kae neneng e teng neneng o thwa ha iyo e tla ta next week. Thank you.
Kana lebitso la mama o rile ke mang?
Mantombi wa Gatebe.
Oh, mme man. Tatabo, akere ne re sena number 13, a ke nyako senya, akere. Ntate, a ke batlo senya because enka walawa. It means somebody else might also say, le nna ke batlo tsena. Akere. And then Laura choose a outside. Or hey, bonweno ke bona bo. Corruption is starta ya. Akere. Or a re tlile ka melao. Ebe rona re zama hore no mo le re no mara mo a retseng why is an exception ro seng akere. So ke kopa re ska senya akere ba holo. Akere dumellang. Le ngutlu ila re simolla re tsa matsoho ba ba nang le kgatlhego. Mare there's nothing and there's nothing that is wrong to engage us even after the session. Akere. So re ka so kwalle le ko ntle completely. We'll still engage you, but I'm saying for the running of the program, re tshaba hore re boele ko morao akere. So re feditse ka mo akere. Ka mo ne re choositse how many hands? 9. Yeah? Ke 9 a le nya go se. Khosi ke yo are ke 9. Ndate ke ka mohlompe. So lona le setšhaba sa ntate ke ka. E re batle batho ba rona ba ba 9 bana ba go kae? Okay, a re simolle ka number 1 ya rona.
Ha ke qale pele ke dumedise ke tapele ya rona e leng teng mo le mme wa rona mme MEC wa rona dumedisa setjhaba kaofela. Ntle le ho senya nako nna ke Esther Gatebe ke chairperson ya ko Rispret Clinic ko rural. Rena le di challenges tse ngata mara ka baka la nako re ifuweng ke tlo matha fela ke re qaqa ka pelenyana. Ya pele rena le challenge ya hore ko rural di patients tsa rona boholo ba tsona ke ma foreigners, and because of that ile di foreigners ho tjho hore boholo wa di patients tsa rona mo jwale ka ile batho ba hlahang ka ntle ke bona be ileng hore medication o ya ho bona haholo. Ha re tjho hore di patients tsa rona ko rural e leng ward 25 ha ba thole medication, but re lokela ho ba proactive. We don't know in the future how to ba jwa, but ne se re fela ke tapele le MEC abe aware ke taba yeno hore most of the patients tse re di fumanang ko rural ke ba kantle. Then point number 2, a serious challenge is the facility ya rona. Our facility is very, very small and if an challenge to our staff, selimo, but sebetsa ka tsela e leng unprofessional in the sense ya hore kore regarding confidentiality in terms of hore ba bona di patients tsa bona jwang is really risky, and the pain part of it is more than plus minus 20 years who renally that kind of a facility. I've got a chairperson yeah this clinic committee, but I've observed because as a patient ba sebetsa ha bohloko ho petetsana, and ho petetsana jwale e painful le ho feta kore our staff they share the toilets with the patient. You can just imagine one toilet. And then ke matha hape ka plenyana the challenge re nang le yona ke issue ya tsona di ambulance, but ba understandang rural go jwang. I think se le anhlokomela hore but ba hla mo di barrage they take more than 2 hours hore ba reach the clinic. Then you can imagine ka ambulance, if collocationing ambulance is a challenge, go rural is worse. Sometimes they don't even get the ambulance. It's painful. But anyhow, enngwe ya dintho tse etsang hore ho be worse ke infrastructure. Ko rural there are no ha hona di-tar roads. So if it's raining, ambulance la ile hore nako e nngwe e available, it can't reach mo e leng kelang hore e tlamehile hore e ye ko teng. Oh, it's a child. Okay, tinqedele kodwa. Okay. And then enye nje yokuqina okuyisicelo lana siyacelela. Since I became a chairperson more, I've realized we don't have the community health workers. Siyacelela ukuthi may please re fumantshwe di health care workers ko Respray clinic. And then le ena ya.
All right. Thank you very much. We must thank you, Mayor Esther. I think when you have got a platform, because you are the chair of the clinic committee. Yeah. So if there's any further issues, obviously through your reports, you can still interface with the department so that you escalate those specific issues. Because it seems as if it's a long list of issues that warrants the immediacy of attention of the department. Maybe let's do it in that fashion, through the submission of our reports. Yeah, let's take number 2.
Ha ke dumedisa ke re protocol observe. Nna lebitso la ka ke Ellen Monamudi. I'm a retired nurse but not tired. I'm
O bozo wena mama Ellen.
I'm
Ara mo shapele matsoho le motlwi.
I'm serving at Albertina Sisulu Clinic as secretary of the clinic committee in Ward 35. Now, MEC, I'm not complaining. I'm fulfilled about the product in Swanti Manese as Albertina Sisulu. Ne ke kopa ba advocate telephone to say two fair. Haba ka thola fela clerical track A1 because we are operating 100% EPWPs. Number 2, the structure. Habana mo manuelang tieteng they are main but ba ho dula batho ba ithuka roomong eo and re fetotse operating room. So the structure is there. How ka re romella fela batho ba DID ba tlo go thusa rona re se tshintsa jwa go ba tebe tea room ya bona. Thank you very much.
All right, let's take number 3. MEC, Mama Mlambo, we may need to find a way. Ludwilen that is lab, Bomme Baraba Khatala, Araba Berikisi, again. They still constitute the necessary capital for the health system. Let's take number 3.
Sanbonani, okhulumayo nothethayo nguGugulethu Chwane. Gugulethu Chwane. I'm from Bupilong, Jokoti Squatter Camp, Ward 23, Vanderbilt Park. Ngemvume yakho chairperson, bengicela nje ukuveza something before ndizospenda 2 minutes of my time ne indaba kabhuti wethu wase Devon yama needles, issue yama needles. Ngicela nje ukusho kuyiqiniso indaba yama needles yale eBuphilongo there is kunemoto enokuza but ngathi yama NGOs ziyi2 enokuzibona zinikeza abofowethu nabodadewethu abazihlaba ngalento. So ithe xa sibabuza singabahlali bathi bona benzela isafety yabodadewethu nabafowethu xa bezihlaba bangatshintshani ngenidli A1. Yayibona basiphendule impendulo basinikeze yona xa sibuza ukuthi why ngoba thina besithatha ngendlela ukuthi ba promoter this thing yokuthi mabazihlabe. Yabona so basiphendule ngaleyo ndlela ukuthi benzela isafety. Then zigcwele naphansi abantwana badlala ngazo bazilahla nalapha phansi gcwele istrata nje ama needles. Yabona yeah. So ndiqale ixesha lami 2 minutes yami ne ndithanda ukubonga MEC kwi report ne ngendaba yase Hendrik Vanderbilt Park singabahlali basevale sakhala. I remember sasise Atteridgeville sikhala nge overcrowding yase Sebokeng Hospital. So ndiyabona ukuthi it was this year early xa beqala indaba yase Hendrik ukuthi Hendrik iyakhuliswa or iyarenewa whatever but ngathi kuthiwa iyakhuliswa. So we say thank you singabahlali basevale kakhulu but sicela ukuthi iphumelele mayisebenze mayigqitywe because overcrowding isase issue enkulu kakhulu esibethayo singabahlali basevale esibhedlela kakhulu nasezikliniki. Dan ke ndathi kuni MMC siyacela ke ni check indaba yokuthi ama structures ama government structures akhona right now asetshenziswayo kakhulu kwi health ngama structures ayekhuwe nguhulumente we-apartheid asetshenziswa kakhulu. So nina anika edi kakhulu but i-population nizamile ukuthi nakhe ama-RDPs then kwafika nabantu bemikhukhu nabantu ababuya ngaphandle kwagcwala but i-structures kusesesi yasimain andazi noba niyandiva na yabona. So then enye futhi ngenxa yesikhathi sininzi ndicela ukubuza MEC nawe Baba Letsoalo ne, is it allowed for any political party ukuthi ihambe iyorana i-campaign within the premises ze government institutions okanye nje ithi ndithi nje kwi-Department of Health kakhulu siyayibona lonto leyo nasesikolweni political parties bafaka izikipa zabo bahambe bayokwenza ama-political campaigns kwi-clinics zethu of which lonto leyo mna ndiyibona iyasiphazamisa kakhulu singabahlali because bathi bafuna ama-ID ama-passport whatever. So mna ngoku xa ndizoya ndisuke endlini kwam ndiphethe i-ID ndiyikhohliwe ngapha ndiyagula uyabona. I'm worried ukuthi next time lonto leyo because kwixesha elizayo endilibonayo izoba nzima. So ndifuna ukubuza ukuthi uthini wena Department of Health. Ndiyabulela kakhulu.
Thank you so much. Thank you very much. Let's take number 4.
Greetings to the House at large, all protocol observed. Before my 2 minutes start, I'm going to be short. Thank you, all protocol observed. I won't say a lot of things, but I'm happy that the relevant people are here. My name is Zwalaki Mnosini from Zone 14, Sebokeng, Ward 30. Before my 2 minutes start, we are happy with the Gauteng High Court in Johannesburg that it interdicted a certain organization that we won't mention from performing various actions. Yeah, we're happy. We're actually happy with the High Court interdict. History is going to judge all the relevant people that are leading harshly. I'm happy that the MEC is here and the MMC is here. I can tell some of you, you go to private institutions to go for your medical aids. But us who are suffering as the communities, the things that we are facing in our clinics, in our hospitals, it's a problem. And we hear some people are used to these things. They come here, they report. There's a person who said he has reported that thing years back, and he's still reporting that thing, and nothing is being done. History is going to judge you harshly, and it must go in your consciences to say there's people that are suffering wherever we are located in the locations. But you people are busy there, flamboyant. We see you flamboyant coming here, but you're not doing anything for us. I'm saying to you, it must appeal to your consciences. History is going to judge you harshly. Thank you very much.
Yeah, Araten so. Baolo, Arafokoseng kebatlo le tipa something. I want to caution you on something. Kebatlo question. Are starter. Wabona aonya gore resolve mathata. You do it with a tonality. Enan le tlhompo ka morayo. Agere. Wa itse mona go nge fitile nya apartheid. Rona re le batho ba bantsho. Ne re bitswa ba re ke you people. You people. O ka re we are lesser people. So it's mostly painful. Hai bua ke motho go borona. Agere. Are you people. Because the moment you do that, you segregate the batho. It is as if others enjoy a particular status in society as against others. Again, There's nothing wrong in critiquing either ourselves as members of the legislature or the department. But when you do that, do it with a spirit of correction. Again, re sa senya, ha re ska senyang kopano ya rona. E be re encourage dilo tse di wrong. Because when you do that, and that is what like, you harden attitudes. Le ka o sa na o tlile o re kopa thuso. For the mere fact that you reference other people as you people, statement is a dangerous thata. Again, Araska rotloetsang dilo tse ding, re faneng tlhompho. Again, mo nang le makoa, we said exactly that. Or mo nang le makoa, a re bontshe makoa ao. But when we come and make sweeping statements, re sa fane le ka hore ke ko kae ko re lemoha mathata. It doesn't assist us. Again, it doesn't assist us at all. Go tshwana nka no tsena ka mara meeting ka re dikolo tsa di bereki. Ke thusitseng at the end of the day. I've not assisted anything. So that is why re nantse re lemisa hore re faneng ka dintlha tse di tseneletseng. Again, mara di etsang ka tlhompho. Tlhompho e botlhokwa. Akere ka mo re batle mo di hero or di heroines. We're just having a conversation and we're reporting. Akere la utlwa ba holo. Ka tlhompho ne. Ra le kopa tswetswe. A re ngo number 5 wa rona.
Dumelang batswadi, nna ka lebitso ke Azania wa ha Letsoalo. So the issues that I want to address tsa ka di two fela regarding health facilities mo ke dulang, what 22 Tshepiso. Issue number 1, the facility is not LGBTQ plus friendly. Number 1. I'll make an example, can't too simple, it's out here, you can even go and check it. Former holo tester for HIV. You have to choose whether you can take female or why you can take male and why you have to take other. And also the other part on the forms, feel as if they are less than. Because why can't it be gender non-binary, eba other? Right? Othering other people is not okay. This is safe. And as people who are educated, I'm sure you know that HIV is more popular amongst the gay community than the clinics. How we are prevented, they'll ask you, whereas you just want to prevent, because what if you get raped and you get pregnant? What are you going to do? So the environment is not safe. Number 2, clinic ya rona e nyane haholo, and it doesn't offer mental health services. So imagine going through the situation of explaining to nurses your sexuality, your gender, and how you identify. And then you don't even have a psychologist to go to say, these are the issues that I'm burdened with in the community, in public facilities, and all of that. I don't know if it's because the nurses or the working staff is uneducated or they're ignorant, but can it be reinforced or aware that these types of people, and they're equal to everyone, you can't treat them as less than. We don't have to state, I am like this, I am attracted to this gender for me to get medical care that I pay for with my taxes. Thank you, I submit.
Thank you very much. Kana lebitso lele o rile ke mang? Wa itse ara utlwa lebitso sentle. Zanele.
Azania.
Oh, Azania. No, thank you very much, Azania. Arze number 6, Waron.
I greet you all in the name of Jesus Christ. My name is Letsoalo Tsotetsi. People don't report their symptoms early enough for them to receive the right treatment on time. This is probably because they don't even know that they have deadly diseases. The Department of Health must push an awareness of educational campaigns where community members are educated about diseases that are easily contracted within their township areas. These diseases are contracted. Diseases like TB is on high contraction level because in our township there's high pollution. High pollution rate is caused by such things. And I'm saying this, it's not directly linked to health, right? But it affects health. It affects our health. And so as members of the provincial legislature, it is your responsibility to partner with other committees and eradicate these issues. Number 2, there was an issue about ambulances being hijacked. It is not the responsibility of civilians to ensure that an ambulance driver is not hijacked. It is the responsibility of lawmakers. As a legislature, you are supposed to partner with other committees, committee of safety, to ensure that these hijackings are stopped. You are the lawmakers.
All right, remotely melese diager. On a le voice ya ba etapele tshwantse re mechanic fela molemo. Re mo lokise fela agere. Community is the center agere of everything. Our communities are the center of the governance systems that we have agere. If re ka no re la fela ko maponisa are community members. Lawmakers are also community members agere. Managers, officials of the Department of Health are also members of the community. Again, so community participation should be appealing in everything. Again, all right, thank you very much. Let's take number 7.
Oh, kalebitso ke bongane ntlapfune. Chairperson Letsoalo ke tla o dumedisa le leadership MEC le committee ya hae. Le community kaofela at large. Ka lebitso ne se hlalositse ke bongane wa Ntlhapho ke tswa mo Ward 25. Specifically ke tswa mo Polokong. So che ne ke na le concern le request. So concern ya ka ke engwe ya di issues tse loreng the speakers tse buileng ka pela ka ne se di thashitse. But ke tla la ka tsa ho reiterate because is very important. The issue ya EM services, the ambulances. I've heard in the presentation to say that there is this thing ya golden hour, of which it's 60 minutes to say the ambulance must arrive and has to take the patient to the health facility. But we are struggling in our communities. This thing, this fella in the paperwork, but when in the practical, they don't happen. Because we are waiting for the ambulance for a very long time. So I hope MEC, you will assist us, Memankomo, so that le push, so that thing it happen, 60 minutes, or a patient be saying, because truly speaking, it does not happen in our townships. Probably they happen somewhere, but in our township, it does not happen, Chair. Secondly, it's an issue request. So I wanted to put a request to you, MEC, in our facility, Johandio Clinic. In our clinic there, we have a dedicated staff. Renale staff is dedicated, who are servicing as well. But the problem now is it starts the clinic itself is overcrowded, MEC. Service about Babangata clinic ya gona is service the township around because there is like GG Esnan clinic, unale zone 20, Haina clinic, there is Westside Park, Haina clinic. And all those particular people, they go to a Joandio clinic, of which even it give overload to the staff of Sarona, Secretary Sakabona as if Nkaraba incompetent. So Nerekopa MEC, because we were told by the time when the clinic hane awa as a thank you, Temkeep, a 20 PTP program. We were told our facility will be 24-hour servicing. So Nerekopa, so please. Hi, so lepel into our clinic is service 24 hours because now we are having a backlog and now it's bad to us. Service is low to some of us. Thank you.
All right, thank you very much. Let's take our number 8.
Dumelang kaofela. Ka lebitso ke Thato, ke hla Boipatong under Ward 3. Dipotso tsa ka di 5. Ya pele, hona jwale di hospital tsa rona hona le this new tendency ya hore you call an ambulance maybe from clinic ba wise Sebokeng hospital or Kopanong hospital, but now motho gona o dula Kopanong hospital a so ka ba thola bed for 2 days We had an incident, ngwana ko gae naza mme ho commit suicide. Sebokeng hospital ba re jwetsitse straight mahlong hore ba mo punisha. O dutse beke kaofela a so ka ba kena ka warding.
So, sorry, ma'am.
Potso ya ka ya bobedi.
Do you have a name?
All right. Moses,
Your case here is serious. That allegation is serious, and I think you should give us specifics on that matter so that we can follow up.
No problem.
Thank you.
Thank you.
Yeah, maybe not now. My anxiety is that if she were to explain, we might go beyond the 2 minutes. She said she has 5 points to represent. Maybe on that one, she can see us after the session, okay? So
No
that
problem.
we take additional notes on the issue. So maybe let's go to the second and the other points.
All right, no problem. And then there's another incident, it's in Wipatong Clinic, whereby it was on a Friday, and then the patient nali beti date ya high. The patient was supposed to go to the clinic on Wednesday, and then abaya clinic inka Friday. That patient is chronic. We love what PDC ya Friday, Saturday, Sunday, what to athlete clinic inka Monday, because bona habana nako ya batho be long hore ba skipile di date tsa bona. Is that allowed? Another issue ke the missing file.
Just hold on. But about translation, we are getting a signal that you are no longer translating. Let's do that. We don't want anybody to fall behind. I'm sorry about that, Tato. Are we fine? Translation. Okay. Let's proceed, Tato.
All right, the third one, kia the mobile transport, ye distributor needles. Eating, kinete. Ya etsahala le Boipatong, Ward 8, Pelamatiki. There's a mobile, I think, ingotu Mangosa, if not mistaken. And then the registration, I do have it. Ki wile lintatori ke tla mo sendela, ha ke fihla hae. They even give those kids dijo. Ba mo fa package ya di needles, benne ba mo fele plastic ya dijo. And then another thing, hona le batho ba nang le bothata ba mahlo. I'm one of those people. Oya clinicing, ba o fe referral, oya Sharpeville clinic, ha o fihla Sharpeville clinic, ba o fe referral ya Sebokeng hospital. Ha o fihla, be ba o jwetsa hore di brele, di tlo nka 2 to 3 years before di thola. People are complaining, batho ba lla. People they can't afford ho reka di brele. Re kopa thuso. Re kopa thuso ka taba ya di brele. And then ya o qetela, ntate Letsoalo, ke a tseba bitse re se ke ra bua ka di sewer and everything. But this one it's a cry, especially mo Boipatong. Hona le ntlo e leng hore batho ba mole ba se ba patile habedi. Ka baka la surishi e tswang ka tlung. Re kopa le buisane le the other committees tse leng hore le tlameha le engage le bona because e serious taba ena. Ga kopa. Thank you.
All right. I think we'll relay. That is why earlier on, Niki Wutsor mo councillor or guy, I get it. Because some of these things are best represented in council. I mean, now only issue surage. Into surage, I have already. Ogrebile ile province, go di legislature. Surage. So my councillor are na lona tshwantsa show me. I get it. But I think we'll just record it and then relay it. The MMC is here, so the MMC is also a council. I get it. The MMC is also a councillor. I think she will refer to the relevant persons or unit. Let's take an.
MCC kuyaleboa ibinge bungekho ungene pha ungavala iphupho wenze so and it's just on the reception area siqale phansi sayichitha sayilungisa Kuzawuvulwa nje soon sifaka abantu for mental health. Athatha amafoto, it's big, it's beautiful like this. Siqala phansi nayo, taking out isane roof zakhona. Zela kitso that HVAC zakhona zihambe kakuhle emergency area yakhona. Ibincinci ipondo elingana nalakona leya. If you have been with me last year, kwakufikela committee yase parliament elidwa nguMayimane. Kwakugcwele abantu ufika niyayazi lonto leyo. Because ngama relative wenu. Last sebetha akaxoki bake bahlale 2 days. Kopanong is the same thing because we're going to work on both accident and emergency areas. Eyasesibukeng sesiyekwela cala siqale phansi futhi contractor is on site to in other areas. Sakufonela tata ndiyaphuma ngo. They are right. I don't want to say they are lying. They are right. Abantu bake bahlale Kopanong. That whilst kuzabe kulungiswa on this side, sabathatha siyobafaka in one of the wards. 3 campaigns, then now Mwepe is adding this new one that we are going to launch. I serve with a smile as a department. We still have staff attitude in other areas. The way that you come across now in the clinics and in the hospitals. And we always appeal to the clinic committees to help us to identify enough staff, asiko enough, uyu 1 or by 2, UTTG, and yona, sizawuthatha ndatepisa ma details ala clinic, sifuna facilities manager asitshele. Every Wednesday, tina department in health, sinxiba amateki ine tracksuit ine tight, because siyasebenza exerciser. Everyone, I said, every manager, every person, you must start with those exercises because you relieve even pressure, the tension on you. So we have those programs, the Wellness Wednesdays. But now TTG is going to tell you, we have employed now other people, young people that are going to do those wellness exercises to the patients that arrive in the clinics. So that when they are still waiting there, they are stretching their hands. They are doing some activities. So we've employed those kids. They are going to help us in the 5 regions to intensify our campaign on Wellness Wednesdays. Because you do that, you are reducing even the diseases. Anybanazo, if you don't do that. See, pick up in the filing. We've started the phases of filing. We're doing e-filing. That clinic, we're going to send a team that has been in Spokane, will take 2 volunteers to go and start sorting it out, e-filing, because we're punching it in the system. We're in a hurry, because we can see the pressure that we're having. Records are getting lost, things are not okay, space, it's not there indeed. Ukalada will take the numbers of those clinics that we must assist in terms of spacing, because if it's basic on us, as Vulela Ngokwet, then we are starting afresh, building a new facility. So educational campaigns, Chair, that resides in my office. I work with the Refilwe, I work with Ndatepiti, I work with the chief directors and directors in all the regions. We have educational programs. Every day, those combis that you see, those are educational programs on local health promotion. We are doing that in the communities. If you clinic yako aiga yenzi, because the people about reside up area, they will be working with you to make sure that those programs are happening in the communities. So sizawunceda ngale indaba ye-EMS nabantwana bam abahle ndiphathi yabantu abayana che that man fika ndiyafunda phakwa EMS zaba nam ndingabanye wabo phayana we say we serve and we belong, but unfortunately ndinibonile bamelihleka. It pains me when you think that you are lying. Masithi abantwana babantu bayabulawa mabesiza kuni bezonceda. South Africa has changed. Amasela ayazimisi ambulance, athathi equipment, athathi phone zabo, ayababetha, ayabawophelela, bayabadlwengula and bayababulala. We have a high number in the whole country, Chetina in Gauteng, of these incidents that has happened. Abanye bahlezi ku wheelchair as we speak, Nani, because of your community members. It may not happen in your community, but don't think that it's not happening everywhere. They are scared of going to communities. And elantu buicho omnye wenu apa, although eilahlele gesgezo, acho njalo amaXhosa. Siyasebenzisana namapolisa ngoku. Because we're integrating our services so that xa sihamba sisiya endaweni sihambe kunye nabo. And Chair, what we have done, we've decentralized ambulances. That is why uzifumana zimile endaweni eyi-1. Umasipala akasena ama-ambulance, ama-ambulance ngawe province. Siyawathatha ke ngoku sithi sicela uwabeka kwiindawo ze-fire, eza-fire what zabo, extinguishers. So that is be protected i-ambulances zethu. But xa ufowuna ucela i-ambulance, iyaphuma la ambulance. And uba kuyatsha iphuma nomuntu wakwamasipala, but ngoku sithe izawuphuma nayo namapolisa, kune-app esesinayo thina esiyibonayo noba i-ambulance ihamba phi na. Xa niyimisa siyayibona uba imiswe phi na. Sikwazi ukuthumela amapolisa ayostopa apha. Why nimile? Babe sometimes kuvaliwe because indlela ayikho. Emikhukhwini khona basokola kakhulu abantu nakwi-rural areas. But it doesn't mean that we can't go there. We may not be 30 minutes, but we do go. But again, we are still saying, thethani nabantu benu, bangababulali, bangababethi, bangabadlwenguli. Etshwane Chair, it's leading, Etshwane, you know. Onel Mapias, I can count it even here in Sebokeng. I called an ambulance myself one day. I had to call the police to escort them just here, Ebupilong. I was there, my family member. At 12 midnight. Funeka ize namapolisa. Then that's another delay that causes these 30 minutes ukuthi masingayi-reach. But sine referral system again esiyenzayo Chair. If isibhedlele sigcwele iSebokeng, i-ambulance ayizukusa eSebokeng noba uyafuna nawe. Sifuna uyotreatwe eTlipek, but we'll take you back then. That's a referral policy that we've done, Chair. That app now that we've put up here bed. Asikusi kwindawo ongazibana bed kuyo ngoku. That app tells us that now you are left with 5 beds in Sebokeng. You can't take the patient in Sebokeng. Take the patient in Bara. So we've clustered even the hospitals so that masikusa etele, you are still having the same doctor wala eSebokeng. Abanye ngabantwana beneni bazeleyo. Simbone siyomsebenzisa etele. It's because ba clusterile. So we are using that so that our services can be easier. On the issue of the clinics, 24 hours, we'll look into that clinic because we are provincializing other clinics. There are those that will work indeed 24 hours, which my team will elaborate on that, Chair. Then, Chair, I think we're trying to do the services, but it's not enough. But with Indabayama foreigners, Chair, the law says don't chase a person ofuna unyangwa a clinic. Dine case yomntana seMalawi ochonileyo because Dudula turned that woman at the gate of the clinic. It's not the Dudula now that is accounting, it's me that must account to human rights. Aba bantu bafuna umntana wabo. It's us as a department now that must bring back la mntana babamfunayo obulewe because ujike emnyango esibhedlele. The law then says treat the patient, you can deal with others after. And that's what we're appealing to yourselves. Let us treat them. You can see the number that it's not us, but if they are sick, those people who are born up, they stay in the township. Bahlale Sharpeville, bahlale Sebokeng, bahlale Bupilong. They are going to go back and sleep with your children. Baba infecting AIDS. So don't be proud that is yabakosha. Ukbakosha kwako, you are making us more sicker as a community. And this country, Chair, will never be in the category of the first world if we are still very low in terms of health services. Sisemvale, South is a developing country, not a developed country, because when we are assessed as a country, we are assessed on health, on education, on community safety, and those are mountains to climb, Tina, and health is number 1 in terms of that. So I want to appeal to you, don't allow your children to chase away these people in the hospitals, because bane TB, bahlala nani kodwa, barenta kuni kwezindlu zenu. So mine TB uzawukhohlelela abantwana bakho maceda lapha. So they are infecting your children, but the Home Affairs and others, the health is part up. We're discussing now, what are the other things that we can do to make sure that everyone that comes here, siyamazi bangibana, sifaka i-app lena ngola system, yoba simrecognize umuntu, ngomnwe ukuthi lo ubethatha amayeza apha, and ulapha. But again, we're having a campaign of working very closely with the churches, So that the religious leaders must help us. Ngoba abantu bayacawa and then yazilandela ezicawe zabo. But kwezethu icawe not kwezabo. Sizakwenza sure sesiqalile esibukeni. Sibeka amayeza phatshe so that umuntu ahamba yolanda amayeza la 3 months treatment yethu. Ayilande pass sign anabefundisi agreements. Balande this treatment there so that we can decline on what Mwepe was raising. There is a huge decline on HAST programs now because of these initiatives that we are doing. But again, the legislature is assessing me on those things. If I don't get decline on diarrhea, on malnutrition, on TB, on HIV and AIDS, and sebenzi with Department of Health. So that's why when we have a number that is going, it's central to the core business of the department. So what you are doing of us, taking us back, you are making this department not to be seen performing. But on infrastructure, ibingekho ukuthanda kwethu. But into esenzileyo siyithathile unominister uvumile chair that we must take maintenance to health. Akayifuna uyibona iDID. Uthi ngudid, including the hospitals that we are going to build. Uthi masingabuildwa ngudid. We must look for other service provider. He told us DPSA, even last week with the meeting with the Premier, he said, take everything to DPSA because we want the proper clinics, proper hospitals that must be finished on time. Because the other clinics that we didn't finish on time here, it was because they were not done by the Department of Health. They were done by this agency, Department of Infrastructure, who has not been helping us. So now I'm standing tall because at least I managed to fight the battle here, DID, of not assisting us up to the level of minister, and the minister accept after the reports that we've given them that there are clinics that we were supposed to open them 10 years back, but as guys, they're just clinics. So we had to finish those clinics with our own money, and DID was taking more money from us. The clinic has finally kupatala 50 million kuyo, but was charged 100 million the clinic. So now we're fighting those things so that this money can go to the Department of Health to service you and your children. So, but one thing I want to leave, Chair, let's do exercises, colleagues, walk around your yard because you will not be sick if you do that. Some of us are sick. Nyanbona nangoba sendi intombe ngonda bakwa health. Belilikoza nakakubipha kwa financing. Chebe. Hayi ngondiyaphela nami ndiyazibona napha kwesa screen ndimhlana nje pha kwesa screen ndandingengakayanga mna bendimkhulu ndityebile but now I'm working with Department of Health. We're hiking, we're walking, we're reducing high blood, diabetes, all these funny diseases because of the exercises that we are doing. So Chendiyabonga, I will leave you with the team to clarify some of the things that colleagues have raised, but we want to apologize where we have not been reaching you in terms of our services in a manner that you want us to do. But let's work together. Clinic committees, they are so committed, Chair, they don't even get money from the department, but we are making sure that we work with them. The last project that I didn't tell you, Chair, that you have in the clinics and hospitals, one clinic, one garden. One hospital, one garden, and it's done by the clinic committees. It's all over, Chair. Asathenga spinach ngokthina sikha egarden esibhedlela naseziklinik. So we want to continue with that because we're creating our own now nutritional programs in the clinics and in the hospitals. And even that program, it's led by the MEC because it's in the MEC's office. This one of the MEC's desk, it's a beautiful thing, Chair, because Nani sound invite her to help us. Sifuna wonke umuntu onengxaki esibhedlele aze kum ndizabe ndihlezi phandle ndimlindile ndikhophile the whole day. That desk is going to be there and we're starting it already and people are appreciating it because it's active. Somebody spoke about the TTG yethu again, that treatment time guarantee yethu nayo sihlanganisa ne-desk to ensure that we reach out to the citizens on time. Chair, ngiyabonga.
Thank you very much, MEC. And please farewell as you are exiting. All right, thank you very much. Anything HOD? Let's hand over to you.
No, thank you very much, Chair. Maybe because MEC has covered quite a lot of ground in terms of the questions that we posed. But I think just to amplify, we're going to package our responses. I will deal with the infrastructure issues that have been raised. DDG Pasane will deal with the issues relating to staff, employment, and so forth. And then Tateslep, unfortunately, Ritas is not here. you'll just have to deal, or there's somebody to deal with the issues of ambulances that has been prominent here. CIO will deal with the issue around e-filing and so forth. So that's how we'll deal with. To start with the infrastructure, what we will do, Chair, in terms of those clinics that have been, identified as not having enough space, we will just request the details of that so that we can go to those clinics and verify that. You might find that some of them are clinics that are run by the municipalities and so forth, but nonetheless, we'll have to come into the space and intervene. There was a question around Kopanong. I think they were referring, Chair, to the APT structures that were left incomplete at Kopanong. Indeed, it's correct, Chair, that at the time, that project was implemented by the implementing agent, which is DID. And unfortunately, what happened has happened. But what is important is what are we doing going forward? We have made sure, Chair, that we put resources for us to be able to complete those structures. We're busy engaging with the Treasury so that we can have a multi-year budget so that we're able to conclude that. We have already undertaken, your engineering studies to make sure and ascertain whether those structures, as they stand, are they fit for purpose. And indeed, those reports, they've came back, confirmed that those structures are fit for purpose, we can continue. So, Kopanong, we're attending to that. But speaking to Sebokeng as well, MEC has made reference to say it's undergoing quite a number of interventions. One of them were to do build a new kitchen for them, with a lot of investment. Chair, we would have informed the committee about our recapitalization program, which we had said at the time when we visited Masakane. It includes your laundries, it includes your kitchens, it includes your mortuaries and all of that. All the mechanical aspects that are in hospitals, it includes that. So we have started to intervene in Sebokeng. Sebokeng also will be going through a facelift. This is what the MEC was talking about, where we'll be facelifting. It's one of the already work has started, but in the main, we must finalize the decanting so that we're able to fast track that particular process. Helderberg, Chair, I think we're there with the committee when we visited the neonatal that we've upgraded, including the equipment, new equipment that we've put there. It is also going the facelifting. Work has already started, Chair. You remember when we were there, the CEO complaining about, the ambulance entrance and how small it was, and so we're expanding that, Chair, and so on. The Joan Haynes project, Chair, you might have seen, I think in the previous week, somebody who decided to publish things without valid and substantive information, which was misleading. The project is a multi-year project. We started in March this year, and what we've done, because this is now going to be converted into a hospital. Initially, it was just to refurbish, leave it as is. But the decision was then taken to say convert it into a district hospital. It therefore means there are certain aspects that you need to introduce, and that is the clinical brief that we're busy with. That EPIT's team have finalized that work. We will now redesign the layout, and by the end of November, the new layout will be there, and will be now in the contractors will be upscaling when that will take 3 years, Chair, because it's massive. It's over $500 million investment that is going into that particular facility. And we must do it right, Chair. We don't want to take 10 years, 10 so on. 3 years it is. And therefore, we're going to bring appropriate and adequate capacity into that space. So that when Kopanong will also be going, Chair, undergoing a facelift that is coming, starting with the accident and emergencies, including your HT, meaning your equipment and so forth. So we'll also be doing that. So for this particular area, Chair, there's quite a lot of investment that we've started to do and that we'll be doing in the future going forward. The issues around clinics, Chair, let me reiterate, Chair, it's quite important because if you want to reduce the numbers going to the hospitals, it means the infrastructure that you put in the clinics must be adequate. So it's something, Chair, that is it's in the part that we're doing. We'll be redirecting quite a number of resources into that area. Chair, without representing the presentation, I think let me hold there and then maybe start with DDG on the issues, and we will go to EMS.
Yeah, let's do that. Mara, re batlo le ko bane go morao. Re utla ona le modumo man. A ke re le botsitse dipotso la ntsha ditletlebo. A re feng lefapha monyetla ke re wa gore o kgone ho araba dipotso tsena. Because ha le sa di utlwe o tshwana fela le tshenyeditse nako a ke re ba hole. A re ba utlwellong gore ba reng. So that in the next cycle of performance reviews, we can say this is what you committed to. Again. So re kopa fela re ba fe monyetla, it won't take too long before we then break. Yeah.
Thank you, Chair. Maybe I'll start with where the MEC left on the issue of physical education. We have, Chair, started a program of appointing young women and men that are qualified in sport programs. So we have started with 5 this year, and we have deployed them in various hospitals in terms of physical fitness. And the fact that Wellness Wednesday are going to extend it to patients in all the facilities. So when the queues are long, they help every patient that is there in terms of exercising, also taking into account the kind of health ailments that they have. And then the other one, Chair Eba buileng ka yona ke, you know, the staff attitude that was raised by Tato. I think it's a matter that even on our side, Human Resources will investigate it. You know, because you cannot punish someone, you know, for being ill, and that is not their space, and will also intensify, you know, the professionalization, you know, of our clinics, as well as the campaign I Serve with a Smile. I've heard Mr. Khatebe talking about, you know, that they are doctors who don't come every day. I think it's a matter that we will investigate and check on what is happening, because of we have appointed many doctors, and we have asked them, you know, they are required actually to come on a daily basis. And the other issue that what we have said is that all hospitals should have, you know, a board that informs all patients that who is the doctor that is supposed to see them. So that, you know, if that doctor does not come, then they can escalate the matter. And then also the issue that was raised was around the community health workers. I can safely say, Chair, we are the only province that started this program, and we have got more than what has been funded by the state, even now when the minister promised us additional funding. But it's a program that we support very much, and we've got more community health workers than all provinces. However, we will ensure that we extend it if Renali Chalet. And then May Ellen also raised an issue of support staff of clerks. I'm going to look at that. So we'll look at the structure and also ensure that if we can't bring in a permanent staff member, we'll bring you an intern that is qualified to can do that. When I say we'll bring it, I'm not gonna run the process will be run from this side. So we'll give them resources to appoint those kind of clerks that are not budgeted for. With EPWP training, Chair, we have trained them in various programs, including that of core services. And now we have also decided that before they leave, they need to go to various facilities, if it's computer programs or data capture, you know, and in-service training before they leave. the issues around the shortage of nurses. Chair, this is one area that we have prioritized of nursing. We have appointed a lot of nurses, even from communities that are retired. Like May Irene, who said that she has retired, but she's not tired. But also we have invested in a lot of programs in our colleges to train, nurses within Gauteng. And we always chair ring fence those positions of nurses for entry level for the nurses from Gauteng who have trained within our facilities. So I think the other issues that have been raised, Chair, are related to staff attitudes and the ill treatment of staff, and we're gonna investigate those and also provide support where it's needed. Thank you.
Chair, we'll require EMS just to comment.
Thank you, Chair. Dumelang baholo. Le kae? I'm standing here, ke nna ka lebitso Jane Kekana. Ke tlo zama hore ngizwile abanye bayakhuluma, ba bang ba bolela, but I'll stick to those languages. And as I stand here, as I said, I'm here to speak on behalf of the ambulances and from the engagements that we had ever since this program iqadile. I have seen hore as EMS we need to start doing community outreach. Ke bona hore ho na le a lot of gaps because of I acknowledge hore community is aware hore the ambulance di teng, but the challenge is, are we then using the correct number? Are we then getting references to then escalate and inform us of your complaints so that we then see where the problem is? But then with the first lady that spoke, she made an indication of Hornaleko Sibeng Mutwen in Zone 12, where she requested an ambulance. And remember, one thing, I think when the first presenter presented, they indicated that EMS has introduced Gauteng scheduled emergency transport. The reason why these ambulances or the project itself, scheduled transport, the ambulance, they will then move around certain routes in the district. It's to ensure that if, for an example, you need to move from Levi Mbata going to Sebokeng, then the facility itself does not need to call for EMS for you to come to be collected. So ambulances ditla certain routes to just drop you off so that then we can alleviate that. So with that one, we'll look into it. I said I'll speak to her and get the details and find out what was the reference number, and then we see where were the other resources on that day. The golden hour, hence I said, I have seen there's a gap. We need to then communicate with our community to be saying when you are in need of an ambulance, if it doesn't come, what are the follow-ups? Because of, remember, we work in an environment there where there's an emergency. And once habaka phone bar there's an accident, remember, irrespective ya hore ne ke ya kae or bare ngwana o thutse ke koloi, I need to then not attend the call elayako clinicing because of there are health practitioners there. I then need to commit to somebody that's out there on the road in an accident to ensure that we provide equal care to everybody. So I want to say, and to the community to be saying, we need to start doing our community outreach. I know in some certain areas of which I cannot recall, there were community members who were given first aid bags. So I'm saying let's work hand in hand and assist each other. And the one year, ambulances, when they get to hospital, I'm going to ask and say to the community once more, we all need to educate each other to be saying, when do we call an ambulance? So that when somebody comes early on an ambulance or in an ambulance, we know that it's an emergency, then we don't question each other, Kayona. Because of that's where I'm also seeing the gap to be saying, when obviously as EMS, when we get to a facility, there is no way that when we find community members sitting, I will then want to disclose, okay, mmotse ke re, ke tlise molwetsi o tshwere ke 1, 2, 3. Let me give the practitioner that's accepting the patient the handover, and then spetlele ke sona se se tla reng, okay, fine, you will then queue, or we will do 1, 2, 3. So hence I'm saying, with the number of ambulances that we're touring as a community, can we let the ambulances hand over and then afterwards release them? Then the hospital itself will then do its procedure, please. And with the Ratanda, the one that said there is no base, there is EMS station, Koratanda, which is 7 kilometers away. So that's why I'm saying we need to do a community outreach. And then the Duncanville, the delay there. Hence, I'm saying we will then attend to it as community leaders of the clinics. Please just ensure that you engage with us as EMS so that then we come down and then we iron out those challenges. The very same with Reed Spruit area. There's a delay as well that they indicated. And Sebokeng as well, the golden hour. Hence, I'm saying I'm standing here as EMS, and all that I'm noting is the gap that we just need to say to you as a community. Re kopa hore le re fe monyetla o helena le di community outreach, so that then we come to you and then we say, this is how you call an ambulance, this is what you do, you request a reference number. If it doesn't come within a certain period, you then do a follow-up and then you find out what is the problem, because of the key is, without communication or without us informing you and finding out what our challenges are, you would not know. But if we then constantly communicate and we try to iron out challenges as and when they arise, then we will then improve. And just to say to you guys, our control center, I know it's in Midrand, and there's a PHOC, which stands for the Provincial Health Operating Center. So what happens there, because they are monitoring the resources key all our vehicles. For each and every vehicle, the ambulance, the tracker. In case if there's an emergency at a certain spot, they can quickly then go to the screen and see which ambulance is available, then can quickly go and service that that emergency. So hence I'm saying, as a community, we're just saying as EMS, correct wherever the gaps are, and we have acknowledged and we are saying, please invite us. I hope I've answered all the questions, and wherever we haven't met the target, we will then improve. I think next time when we move, we will see the green by in EMS. Thank you.
Thank you very much. Ke bona bontate ba ntshitse matlho ba pay attention. Hey. Abe le rata dilo. Abe mme o a bua go re itse or le pay le close attention. Ra le bo hona man. O tla man. CIO.
Okay, thanks very much, Chair. And so some we explain ngesixhosa but zofaka in English. So there were three things that were raised on the floor, Chair. The first thing, I think it was Mayor Jacqueline, on the issue of the missing files. So what the department is doing is that we have started a project called e-digitization. The purpose of the e-digitization is to actually digitize all those manual files right into digital records. So far we have done BARA, we've completed about 800,000 records. This project is done in phases, right? So now we are on phase 2, where we're going to be digitizing all the 37 hospitals, right? The project is meant to run for a period of 3 years. But in the same vein, we're also going to be starting the CHCs. But you'll recall that this project is quite demanding in terms of money. So we want to start with the hospitals. Once we are done with the hospitals, we're going to do the CHCs. Once we are done with the CHCs, then we're going to do the clinics. But in addition, we have got records managers, that at least those records that are sitting in the PHC level, at least they can be managed, they can be scanned, and they can be sorted, so that by the time we start the e-digitization, we can be able just to start that process and smoothen the whole project in terms of the digitization process. So on the issue of the queues, As well, we have started a project called the Integrated Queue Management System so that you don't have to wait that long. So far, we've started at Rahima Musa as well as at Charlotte. So now we are just rolling that project to the additional 8 hospitals with audit that has been done already. With the health information system, I must indicate that we've got a system called HIS. It's an integrated health information system. It does have got a unique number so that if you move from one hospital to another hospital, it will be able to identify so that you don't have to have a repetitive, file. So what is just the weakness of that system by design is that it was not designed to connect at Home Affairs so that we can be able to answer that issue of the foreigners. So what we are doing just to enhance the security is that now we are connecting the system to Home Affairs so that when you come to our facilities, you're gonna give your ID number, that ID number will be validated at Home Affairs. Then it will tell if you are a South African or non-South African. Currently, that system is doing it internally on its own. By the way, we're supposed to have that meeting today so that we can integrate with Home Affairs. We even have a meeting with the minister last week, Friday. It's a matter that we are busy we are busy attending to. The system has been rolled out in all the 37 hospitals as well as the 33 CHCs. We are also looking to roll it out, Chair, on the clinics itself. So it's something that we're already looking at employing. Thanks very much, Chair.
All right, thank you very much.
No, Chair, we will just take on that bit, the last on the service at the clinics.
Yeah, let's take the last and then we wrap up. Ntwele CIO, yeah, ICT, we need to move swiftly. We're falling behind because there are network issues in a number of clinics. So this experience by the community or the file, it's a real experience. You know, it's not far-fetched. So no sooner we resolve ourselves on integrating our systems, the better. And they must be optimally functional. Again. Okay. That depends.
Thanks, Honorable Chair, committee members, and the community. Chair, I think colleagues have shared a lot of the responses in terms of the issues raised, but specific issues for specific clinics. I will be visiting those facilities to go and check on those issues and make sure that we correct them starting next week so that we don't have this kind of issues happening in our facilities. That's the commitment I'm making here so that we work together with the community to resolve the issues. Thank you very much.
All right, thank you very much. I'm going to invite the MMC. Mara ke batla ntate Sambo ga o tsamaile. Wa itse why? Ona le ntho nngwe botlhokwa re itse ke ntate Motaung mo. Ya hore how do we leverage opportunities? Ara ba tlo tsama mo dikopanong tsa rona. Re sa bui ka moruo, akere. Lefapha le le lona le na le di opportunities tse di presentang, akere. Ho na le hore motlhomo kore o advertise wa re ditshebeletso tse re batla batho ba le hore ba mo kgwebong. We also want to empower you. Ara batle fela le nne at the receiving end. So ntate Motaung is a relevant question. Ntate Sam, if you can just speak about how the community can leverage procurement opportunities, because ntate Motaung would have raised it. Again, I can point because when often at times we look at the indicators of the number of youth-based enterprises, people with disabilities, military veterans. They may not have asked that question, but Ntate Motaung would have represented it for it. So I thought, let's also quickly deal with it.
Dumelang, le kae? Re mabapi le di opportunities tsa ko procurement. Normally ko national, re na le what we call a central supplier database, e re bitsang CSD. So, if unale company, either ya o supplier dijo, ya o supplier cleaning material or whatever it o supplier, or register go yona in that national supplier database, the CSD. Now, mo provincing, we went a step further. So we also maintain our own database as a provincial government. Why Letsoalo? So that we are then able to focus on the service providers tsa mo Gauteng, in a specific region and so forth. So liteng mo Gauteng in our provincial treasury, you can go and register. Once you must firstly start go national supplier database. Once only that registration number, we go Gauteng treasury, go Fox Street, where you then register to be in a Gauteng supplier database. So database here is very important because what they do, more health, renally agreement le provincial treasury, or every month, batla refer the supplier database, redistribute ko dipetlele. Akere dipetlele di a ithekela. Whatever ba batlang, if ba batla o reka pampiri, ba ithekela pampiri, if ba batla o etsa catering, ba iketsetsa catering. So what we have done with the agreement, the provincial treasury, we've agreed to refer that supplier database because we are targeting the service provider selling registered and the elite service provider tsa mo townshipping. So that is what we are prioritizing. And also if elite service owned youth, and also if elite service providers say owned bomme, and happily service providers say owned people who are living with disabilities. So those are the service providers that we are prioritizing. Now every month we get that database and we source and request database here. Reba kope re ba refer quotation. Once you are lower, we appoint you or refer the service that we require. So it's important, two things, registered national and register co-provincial treasury, co-78 Fox Street. And then you'll get the opportunities. Thank you.
Thank you very much, Ntate Sambu. Ko bofelong, e re feng MMC wa rona monyetla ke moetapele wa rona le ena kgono etsa her reflections. MMC?
Ke leboha, dumelang baahi, ke a kgola se le tshwere ke tla. Ra wrap up no. Ke thabela ho bona le tlile ka bongata bo le tlileng ka bona. That shows hore re batho ba responsible. I'm happy ho bona bongata bo re tlileng ka bona because of the issues still in le tsona, and then the legislature it tlile hore it tlo address all those that we have. So li ikutlwetse akere mara monyako wa ka o ntse sa kwalwa, office ya ka ntse sa kwalwa le phone ya ka la nka ka checka WhatsApp no se ke na le 100 and something ya di WhatsApp. So re a leka re le puso ya Sedibeng hore re fane ka ditlhoko re le tsebisa hore department e se e le hokae ho etsahala eng. Nna ke thabile mo ke leng teng, and I hope le mo le dutseng teng le ikutlwetse ka ho ikutlwela hore department e hokae ka everything e etsahalang ka hare ho Sedibeng. And then le ske la tshetsela morao batho ba vale ke kopa le registereng le kgone ho fiwa mesebetsi le lona re ske ga lla fela re ntse re sa khotsofala re ya di radio stationeng re bua ka mgo. Wake up, go there and register hore company ya hao e kgone ho nominateiwa e etse o fiwe something o kgone ho sebetsa le wena mo o dulang teng. O ske wa tshetsela morao, o ske wa batla ebe next door wena o sa yeme ka maoto. And le ha o bona something e sa thabising itlo o tlo report bontate le bomme ba se ba buile. You don't utla ka false information hore batho ba department ba etsa so e le hore ha se nnete. Hobane matsatsi a ka je ke a tseba la videolize ho thu etswang ba di TikTok and all that, la TikToker and all that. So high information is yone. Ntho ya pele re bona TikTokong because batho ba shasha ba kenya social media hore embarrass or whatever case or some kind of reporting. But we acknowledge how little ka bongata bo hore le tlo ikutlwela from the department itself. Le nna office e butse ke bone councillor Mthimkhulu ke tse bosotswile nako o bone councillor. I'm happy you are here. I'm truly happy that you are here. Some of the issues I hope you've heard from the department tso lenkhalo di raise le nna ene se botlhoka ke se MEC a se buileng hore ha re tebele batho ko ditleliniking ba gaetso ha re tebele batho because health is for all of us and MEC o hlalositse le nna ke sa hlalosa hore motho o mo tebelang o hirile jarteng ko wena ha kula ke TB o tebetswe ko tleliniking o tlo tshwaetsa bana ba hao le wena ka motlung. So we need to consider such things hore re be responsible citizens at the end of the day. Re leke hore re fole and re phile hantle at the end of the day. Ke a leboha modulasetulo, ke a leboha setjhaba sa Valley, ke lebohela bo ngata bo letlileng ka bona. Thank you so much.
Yeah, erekele leboeng le nna. Re tsama tswa ba fello a mateti. Akere 30 hands are one. No, but thank you very much. Let me thank you. Batho ba ka mona ba Gauteng le ba ka mo Raval, akere Greater Val. Aba la tshwanno itshoa. Ne re le bitsa pele re Greater Val. Maro ka re le na lo inyenyefatsa. Le na lo tshoa go lutlile le bitsa mabitso a lona. Akere a bua lebitso la o tshwantse wa itse o le bue ka manontlhontlo o re nna ke nna Ezra o re holo e dume akere mare ke rato le leboa le buile bontle man mme Esther Gadebe mme Molambo mme Gulu Zwela ke Azani ya Lesedi Ntapo Thato Meja Kwelini, Ntate Thulane, Ntate Motau, Ntate Mofokeng, Meha Debe, Boiswile Thamsanqas Manga Mishaki, Ntate William, Ntate Lawrence, Ntate Joani, Ntate Zoli, kaofela le buile bontle man. Akere rato le boa la bona re recordile lo tse tsotlhe tse le di buile. Re di tshwere. So ere ya go pele, rona ntse re bua le lefapha re batho ba rile. Le berekile bjang ka dintlha tsela akere go na le tse ding tse le reng mohlomong MMC a di arabiwa ka re di recordile rona re tlo di sala morago akere ntho ele ya di foreign nationals ntato mongwe e buile mo gore dipetlele tsa rona di a overcrowded o na le mme o moleno o buile gore mare di political campaigns di allowed mo di institutions tsa rona di a dumellesega akere so there are many other things that we are going to follow up as the portfolio committee akere Marintumelleng ke le leboeng for your discipline and for your humility. Le re bontshitse botho le rona re le maloko a committee e tswang go legislature. Akere ke rato le bua le maloko a leng teng ka mo ke lewe le bo mme le bo ntate ba ile re ba etelletse pele le nano le ntate ko pele kwa le motlwile o le kila akere so rato le bua kaofela akere so Mona go nya ona ba none re fedisa kopano ya rona mare a re batlo re le phatlalle fela akere re sambane re tlo interact re tshentshana di number bo mme ba ile reng akere lampona re le tambotsa akere so ne kere o tlhalose gore tsamaiso ya bo di lunch e tsamayang akere e re mme a re tlhalosetse gore lunch di tsamayang
Lunch will be served. Lunch is a server when you exit through the door. Thank you so much.
Me o ke ra tlhalose lena o e betha ka samare so ba re lunch ha le tswa ba le fa yona akere mare akere re bereka ka tlhompo la itse a o tsweng batho ba bagolo pele ba bagolo re ba bitsa re ke high caliber. Bomme Jacqueline, I give me man. Me ole gana give me man, Mamara, I'm not, Memlambo. Worry, I'm retired, but I'm not tired. Who's about Memlambo Bailey? I get me Mamlam. Who's all na Bailey? It was about me. It was about re. It was lavage. I get. I get go parade now. I get. Really lebuile. I got the mind sent them with the marble. I get. Thank you.